like to thank the KBC organizers for the kind invitation. It's a great pleasure to participate in this very special meeting. Okay, without further delay, I'd like to start my talk, which is about techniques and advanced maneuvers for difficult side branch access. I have no disclosures regarding this presentation. I would like to start highlighting the importance of the good pot technique, which is crucial to open the struts across the side branch osteum, and this technique may facilitate side branch preservation. This is an example of how pot can help in open or reaccessing the side branch during bifurcation PCI. This patient had a proximal LAD severe stenosis with a big septal involvement, and after the main vessel stenting, the first septal went down, and the patient starts complaining of chest pain and start to have tachycardia, and we are not able to wire the first septal. Then we decide to perform the pot maneuver just close to the septal that went down, and after this maneuver, we could recover the septal flow and reaccess and perform balloon angioplasty, and we got this nice result. These are the common problems that we find in such situations of steep angulated side branches. It's difficult to advance the wire in the opposite direction of the main branch because of the natural tendency of the wire to keep going towards the main branch. And as we have more tortuosity and calcification, we have loss of torque response and loss of support due to high angulation and due to this proximal tortuosity. So the wires become not to respond well. So these are two important wire bending wire shapes to access difficult and angulated side branch, the double bend curve and the progressive curve, as you can see here. So this is an example of multi-vessel PCI. We start doing the RCA, which was CTO, and after that we went for the left main and LAD with diffuse disease, and we actually planned to work as fast as we can. It was the last case of the day. We start with provisional approach, and we didn't put the wire on this diagonal branch, and what happened is after standing from left main to LAD, we got TM2 flow on the diagonal branch. We had no wire on it, and after a few minutes, the flow was getting worse, and finally we lost the side branch. The patient has ST elevation, chest pain, tachycardia, and what we did, this is our approach for this kind of side branch acute occlusion. We start dealing with wires. We choose non-polymeric workhorse wires, then we change for polymeric workhorse, then we change to polymeric taper wires and some specialty wires. These are some options of these wires. We start with a regular 3 to 4 millimeter curve. This case was easily solved using the Boston fighter wire, which actually was very gently manipulated to seek the channel and through the struts, and could easily wire and do balloon angioplasty and restore. This is the final result with the flow restoration on the diagonal branch. These are some advanced solutions for side branch wiring in challenging anatomies that I would like to share with you. Some of them that may help in difficult situations. For the sake of time, I'll show a couple of these solutions for you. First of all, the use of double lumen catheters. In my country, in Brazil, there are two double lumen catheters available. The Sasuke from Asahi, which is a very low profile double lumen catheter with the side port very close to the tip, and there's a different one called twin pass from Teleflex, and this is a little bit bulky microcatheter, and the side port is a little bit far from the tip of the microcatheter. Example from a more complex case, a CTO case with distal cap involved bifurcation, and after the retrograde and B2B directional approach for recanalization, we had to deal with a bifurcation, and we did a mini crush, and we had very difficult time to rewire through the side branch struts, and we used the twin pass double lumen catheter with a whisper wire to access through the struts of the side branch and achieve a good result. This is the important technique, the reverse wiring technique, which is very important to know it. It can help in some situations. These are the best bifurcation angles with a Carina angle more than 90 degrees and the takeoff angle less than 90 degrees. This is the best scenario for the reverse wiring technique, which consists in advancement of the hairpin shaped wire, and with the gentle pullback, we do the reverse wiring of the angulated side branch. This is the classical description that was published in CCI in 2007, which the hairpin shaped wire is advanced through the tohi. Nowadays, we changed this technique for a new iteration, which called streamline reverse wiring technique. And this is a very interesting technique. I wrote something about it in this article. You can seek for this technique here. I'll show you that the main difference is that we form the hairpin shape inside the coronary tree. We don't need it to advance it alongside the coronary. So this is an example of LAD, diagonal bifurcation, calcify. We try to advance the IVOS catheter, it won't cross. We did rotulation, and we start the IVOS evaluation, a lot of calcium, protruding to the lumen, some nodular calcium, eccentric calcium, and we had a hard time to wire the diagonal. Actually, we couldn't wire with many wires and different shapes, and we had a double lumen catheter to the system, and even with double lumen catheter, we could not wire the side branch. So we changed it for the reverse wiring, streamlined reverse wiring technique, which consists in selecting a distal side branch, in this case a septal branch, and pushing the double lumen catheter to actually form the hairpin shaped wire inside the coronary. And after that, with gentle movements of pullback the double lumen catheter, we would engage the side branch osteon in the reverse fashion and proceed with the reverse wiring technique, which you can see here. Gentle movements, and the wire goes in the side branch. And after that, side branch was secured, and we proceed with double stenting technique. In this case, was a TK crush with some IVOS optimization. We achieved a final, this very nice result. And when nothing works, we have to think outside the box. This is an example of LAD, diagonal bifurcation, a very acute retroflex angle of the side branch. We tried our best to manage it, but we cannot wire the side branch due to this acute and retroflex angulation. And after 30 minutes of attempts to wire main operators, main wires, main shapes of the wire reshaping, we decided to move to a different technique. We use an unconventional microcatheter, a microcatheter that is used in neurology, neurointervention. So it's a shapeable microcatheter. We use a repeat gun to shape this microcatheter. We didn't have the pre-shaped microcatheter like Supercross at that time, so we decided to shape our own microcatheter with a very acute shape. We delivered the microcatheter with a workhorse wire, and we pull back the wire, and we did some kind of very gentle micro catheterization of the side branch, like XP shape, Fodder shape. We could engage the osteon of the side branch, and we gentle proceed with the wiring of the side branch. With this is echelon 10 microcatheter. This is the name of the microcatheter. This is a Fielder FC wire, and the Fielder just go very smoothly through the side branch. And we could advance the microcatheter and put extra support wire, and we proceed with the double stenting with DK crush. And this is the final kissing balloon, and this is the final result. Thank you.
Evandro, could you hear me? Evandro? Hello? It's Manuel. Could you hear us? Morning, Evandro. Evandro, ¿podemos conectar con Evandro? Evandro, in the meantime, some comments from the panel.
Yeah, this was an excellent presentation, and maybe you can ask the panel regarding this strategy to access the side branch. I think sometimes when the side branch is very precious, then we can start with wiring the side branch before we do the main branch. And I don't know if he prefers certain wires when there is very difficult access to side branch. Do you prefer? Of course, we had seen this initiative to use the microcath, but what is the kind of wires you are using? And do you prefer to wire the side branch before when it is a precious side branch?
Okay. ¿Tenemos conexión con Evandro o no? Evandro? Hello.
Sí, estoy aquí. I can hear
hello,
you.
hello. Thank you for participation. Another question from the audience? Another comment? If not, from the panel?
Yes, just congratulations for the excellent presentation and for the very difficult cases that you showed us. And yeah, I especially love that modified microcatheter technique and with the reverse wire. So I think we can use it afterwards, but it was an excellent press. And also, what's very interesting that if you have very complex anatomy of the of the bifurcation. It's sometimes extremely tough to get a wire, no matter what kind of wire. And you get started, and then after 30 minutes, you lose some of your patience. And after losing some of that patience, you have some different ideas that come from different parts of your mind that's probably would not be normal. So congratulations for that, and also the reverse wire technique or the hairpin wire technique is always there if you have some microcatheter on the table. But so congratulations on an excellent presentation.
Thank you very much.
Okay, Evandro, thank you. Congratulations again, and we have to move to the next presentation. This is technique effect of wire gelling at side branch in one stent strategy for coronary bifurcation lesion that is going to be presented by Byeong-Keuk Kim. May we have the presentation?
Good afternoon, everyone. My name is Byeong-Keuk Kim from Yonsei University Severance Cardiovascular Hospital. Today's my talk is the effect of wire gelling at side branchy and one stent strategy for coronary bifurcation lesions. This is my disclosure. Let me start with the LAD diagonal bifurcation case. For the treatment of diffuse long LAD stenosis, 2 DS were implanted with overlapping. However, on angiograms, diagonal branchy was occluded after stenting. We tried to save diagonal branchy from the start of the wiring to the Zheng diagonal branchy, but finally failed. To protect the side branchy during bifurcation PCI with one stent technique, numerous strategies has been developed on the basis of wire gelling. It is recommended gelling wire technique in bifurcation PCI, but concerns still remain, particularly data regarding the impact of side branch gelling technique for bifurcation PCI with one stent technique using second generation DES are limited. Thus, we recently reported the analysis regarding the role of wire gelling at the side branchy and the major determining factor for side branch occlusion after stenting using the data of the COVID-3 registry. COVID-3 include patients with bifurcation undergoing PCI with the second generation DS implantation. From COVID-3 registries, a total of the 890 patients with bifurcation PCI using one stent technique were finally enrolled and classified into 2 groups according to whether they underwent wire gelling at the side branch, the wire gelling group and non-wire gelling group, to investigate the pure role of the side branch wiring in one stent strategy. Coronary bifurcation lesions requiring side branches such as the first is elective 2-stent technique, the second is a side branch predilation before stenting. The significant stenosis, only a side branch without significant main vessel stenosis were excluded in the analysis. Primary endpoint was the occurrence of the final side branch occlusion after main vessel stenting. This is the comparison of the baseline characteristics between 2 groups. There were no significant difference. This is the angiographic and procedural characteristics of both groups. There was significant difference in the location and classification of bifurcation lesion. The wire gelling group compared with non-wire gelling group had higher instance of left main and true bifurcation, with a higher instance of the heavy side branch calcification or thrombus. DS type and the use of the IVUS were also significantly different. On the comparison of the QCA data in the pre-procedural analysis, the wire gelling group had a shorter immediately greater diameter stenosis, longer lesion lengths of side branch, and shorter lengths of main vessel compared with the non-wire gelling group. In the post-procedure QCAs, there was no significant difference. When you look at the angiographic and procedural outcome, especially the occurrence of primary outcomes, the final side branch occlusion, there was no significant difference. In the instance of any overlapped side branch occlusion, also no difference. However, the instance of the side branch flow restoration after overlapped occlusion were significantly higher in wire gelling group. Angiographic and procedural success were not significantly different, and there was no case of the broken wire in this study. Regarding the treatment of bifurcation lesion, the wire drilling group had a significantly higher rate of the final kissing balloon part, ballooning or stenting in the side branch, and NC ballooning than did the non-wire drilling group. When analyzing the determinant of for final side branch occlusion after stenting, wire drilling and side branch were significant factor, along with the greater pre-procedure diameter stenosis of the side branch main vessel and lesion length. In the analysis of the risk for final side branch occlusion in lesions with significant predictors, the risk of occlusion progressively increased as the pre-procedure diameter stenosis of the side branch and main vessel and the main lesion length increased. On our analysis, pre-procedure diameter stenosis of side branch was 51%, main vessel was 0%, and the lesion length was 14 millimeter. When comparing the instance of the final side branch occlusion according to the stenosis and lesion length, the lesion with a tight side branch and main vessel stenosis and long main vessel lesions show the highest instance of side branch occlusion among the subset. When comparing final side branch occlusion according to the disease severity and wire drilling and side branch, although the instance of final occlusion after stenting in all patients were not significantly different between two groups, the wire drilling group had a significant low instance of final occlusion in the lesion with pre-procedure diameter stenosis of side branch of greater than 60% or main vessel of greater than 60%. In the comparison of the instance of final side branch occlusion according to the wire drilling at the side branch and the severity of the stenosis of side branch 1 main vessel, the wire drilling group had a significantly lower instance of final side branch occlusion in the lesion with the pre-procedure diameter stenosis of the greater than 60% and main vessel of greater than 60%. However, among the other subset with pre-procedure diameter stenosis of side branch less than 60% while main vessel of less than 60%, there was no significant difference in the instance of final side branches between the group. When you look at the clinical outcomes according to the wire drilling, there was no significant difference. Ladies and gentlemen, this is my take-home message. In overall, bifurcation lesion treated with one stent strategy, wire drilling as side branches was not associated with reduced risk of final side branch occlusion. That means the routine wire drilling as side branch does not need to be recommended. Wire drilling as side branch before main vessel stenting was a protective factor against the final side branch occlusion after main vessel stenting in one stent strategy, especially in the lesion with the pre-procedure diameter stenosis of the side branches greater than 60%, main vessel greater than 60%. Wire drilling was significantly associated with low instance of final side branch occlusion than non-wire drilling. This suggests that the beneficial role of wire drilling for specific lesion subset is meaning the severe stenosis of both side branch and main vessel stenosis or true vacation in the wire in stent strategy. Thank you for your attention.
Thank you, Dr. Kim, for your presentation. This is an interesting study with a conclusion that seems to be change our routine clinical practice, because we normally put a wire at the side branch disregarding the morphology and disregarding the severity of the stenosis, because we know that in cases of pseudo-bifurcation, Medina XX0, but with an unfavorable morphology of the carina, the side branch can suffer a compromise. So we recommend in general the use of the gelled wire in all cases. I don't know if your study changed this paradigm. What do you think?
Okay, so actually everybody knows even if there was a severe stenosis of main vessel and side branch, everybody firstly think the wire gelling would be required or not. But sometimes we miss this procedure, and also there is quite related with the final balloon occlusion. So from the data, but before the meaning of the this study, so we should know I previously told you we should know the exact inclusion criteria. So in these studies, the side branch diameter is relatively large, meaning the diameter is 2.3, greater than 2.3, and also is all bifurcation lesions requiring the side branch stenting or pre-dilation lesion is also excluded. So, but in the pure true bifurcation lesions, definitely the wire gelling is needed. But moderate or mild side branch disease or main vessel disease is definitely routine wire gelling is not recommended. It is our study suggested.
Okay. Any question from the panel?
Of the side branch and the angle of the side branch, do they affect the final side branch occlusion? And what about the outcome in this study? If the angle is too narrow or it is too wide?
It is a very good comment, and also we detailed analysis regarding the angulation of side branch. But so from the data, there was no significant difference. So maybe some acute angle or the wide angles might affect the outcome, but in our study, there was no significant difference according to the degree of the angulation.
Can I have just one more comment also? You showed that there was a very high number of both groups, so about 1,000 patients. And you showed that there was a difference, or was there any cutoff value for what you, or what it was left to the operator's discretion to put a geode wire into the side branch? Or was there any angulation cutoff value, or was there any I don't know, calcium score, because there was a very high value of very high degree of IVUS being done for these patients, and also I guess it was also performed for the side branch. So we all know that the angle of the anatomy, the complexity, and the severity of the calcium score, they all account for side branch occlusion. So was there any, because it wasn't just not clear for me at least to see that, was there any cutoff value for the operator to put a geode wire, because there was a big difference in that, in those groups, and was there any IVUS, I don't know, recommendation, or was there any IVUS value, or was there any calcium score measured at least for all the patients for the side branch? Because we all know that there are very difficult, or maybe below 30 degrees or 60 degrees of the angle of the side branch, and if you have a 2.5 millimeter vessel, and also if you have a long lesion that's 5 millimeter, more than 5 millimeter into the side branch, those are all factors that would at least account for side branch occlusion. So was there any IVUS guidance for this, or just a feeling of the operator's discretion?
Yeah, so actually, in this study we just analysis the IVUS use or not, but when and how to use the IVUS for the wire gelling there is no exact data. So, but you suggested some degree, and also is the role of the IVUS for the wire gelling or wire rewiring is very important. Yes, in the future, so we should investigate again. Thank you.
Last question by Carlos.
Thank
Short,
you very,
please.
thank you very much, Professor Kim, for your work. It's perfectly done. I think I just want to note that there are other benefits when passing the guide wire to the side branch besides the acute occlusion of the side branch, which is shorter times when recrossing to the side branch, less radiation time when recrossing. So there are other benefits beyond this acute occlusion of the side branch when doing the protection of the side branch. Have you ever noticed that? Have you ever, studied that?
No. So
Radiation
actually,
times?
We did not check some procedure time related this one, but as I previous show you, but the optimization technique is old optimization technique is more frequently and more easily in wire gelling group. So you mentioned some efficacy for this is, for example, check time of the procedure time or radiation time. That is also very important, but in our analysis was not included.
Thierry, the last one. No? Okay, we will discuss this topic in our next EBC consensus. So we have to move to the next presentation by Dr. Zheyong Huang, and the title is Double Kissing Inflation Outside of the Stent. Please.
Hello everyone, I'm honored to be here to introduce a modified gelled balloon technique for coronary bifurcation lesion. I am Huang Zheyong from Zhongshan Hospital, Fudan University in China. As you know, provisional stenting is preferred for bifurcation lesion, and its key technique is by side branch protection. There are many protection techniques. The gelled balloon technique is most accepted nowadays. Here is the illustration of gelled balloon technique, GBT. A balloon was placed at the oscium or side branch, may be active or passive when the stent put in the main vessel. Then the balloon was removed and post-dilation was performed. Generally speaking, the GBT gelled balloon technique is very, very effective. However, sometimes side branch occlusion will occur, most in two circumstances. The first is at stage of post-dilation. The second stage is side branch rewiring. Here is a case of side branch occlusion and post-dilation. As you see, the marginal branch is open during the passive protection. However, after post-dilation, the marginal branch was totally occluded. And here is another case of side branch occlusion caused by rewiring. The diagonal was open during its active protection. However, during its rewiring, the diagonal branch is dissected and occluded. The JBT is very effective. However, side branch occlusion can also occur due to post-dilation, because post-dilation can cause plaque shift, can cause carina shift, and plaque dissection. So how to deal with this residual risk of side branch occlusion? We should protection side branch persistently, not only at the stage of the stenting stage, but also at the stage of post-dilation. During post-dilation, the gelled balloon should remain at the side branch, and this constitutes the second time of kissing balloon. And so we proposed the modified technique, namely DKO, double kissing inflation outside the stent. There are two types of kissing balloon. The first is the kissing between the stent balloon and gelled balloon. And the second kissing is between the post-dilation balloon and the gelled balloon. Now let's see a case. Here is a bifurcation of the LAD and the diagonal. The diagonal is very large and very important, so we adopted the KO technique to protect it. Firstly, we pre-dilate the LAD and diagonal. Then we put a stent in LAD while active protecting the diagonal. This is the first time of kissing, the kissing between the stent balloon and the gelled balloon. Then we remove the stent balloon. We advance a post-dilation balloon and post-dilate the distal stent, and then the post-dilation balloon and the gelled balloon was inflated simultaneously. This is the second kissing. The second kissing is between the gelled balloon and post-dilation balloon. After the second time kissing, the gelled balloon was finally carefully removed. POT was performed. Another stent in the approximate LAD and LM. Here is the final angiogram, shows good result. And to examine the ostium of the diagonal, we perform OCT both from LAD and diagonal. From here, we can see the diameter of diagonal ostium is about 1.9 millimeter. And so there are three key steps of DKO technique. The first is the first kissing, the second kissing, and POT. The difference between the DKO technique and traditional JBT technique is the second kissing. The DKO technique have the second kissing, the kissing between the post-dilation balloon and the gelled balloon. And here is tips of DKO technique. Between the two-time kissing, the side branch balloon can either inflated or deflated. Inflation or deflation both are okay. At the stage of the second kissing, the overlap of the post-dilation balloon should be least or minimal. This can facilitate the removal of the gelled balloon. At the stage of POT, the distal end of balloon should not exceed the ostium of side branch. So we think DKO may protect side branch better than JBT for bifurcation lesion, and RCT is warranted to confirm its benefit. Thank you.
Thank you for the presentation. Comments from the panel?
So if I can say something, I'm Francesco Lavarra, in remote. I would like to say that in this case, you don't reopen the struts of side branch. So it's not a real kissing for side branch, it's only stenting main branch. So this procedure is just to keep open the side branch. But actually there is no real kissing to reopen side branch.
Doctor.
Okay, so sorry, please speak slowly because my English is not so good.
So you do double kissing, jailing, and then at the end you do POT for proximal part because you want to reduce malapposition on proximal part.
Yes.
But then this doesn't reopen the struts in front of the ostium of side branch. So it's just to keep open the side branch without real kissing main branch, side branch. Because if you do a pot, is a kind of pot without kissing. Is this true?
We should do pot in every patient, but the position should be precisely positioned and should not exceed the ostium of the side branch.
Okay.
Okay. Is there any concern that some stent deformation may happen with this balloon inflated, and also some concern that this gel balloon may not be, we are not able to extract it out if the main branch stent was already fully inflated? So this may need a certain experience in hand, otherwise it will end up with a problem.
You mean the difficulty of the pour out of the gel balloon?
Yeah, the removal and also stent deformation of the main stent with this balloon inflated. Did you have IVUS and OCT had made sure that there is no stent deformation in spite of this side branch? And if you are using a bigger balloon, the side branch is a little bit bigger. So are you sure that there is no stent deformation?
Yeah, after pot at the proximal part of the main vessel, there is no obvious deformation in the proximal part of the stent.
Thank you. We have to
so
move.
The pot is important.
Okay. Thank you. We have to move for the next presentation by Dr. Zheng on the same topic, active versus conventional side branch protection strategy for coronary bifurcation lesions. Please, may we have the presentation?
Distinguished professors and colleagues, good afternoon. I'm Zheng from Peking University First Hospital. Today, I'd like to talk about active side branch protection strategy in coronary bifurcation lesion treatment. And I have no conflict of interest to disclose. According to the current guideline, provisional side branch stenting strategy is a first-line recommendation for most of coronary bifurcation lesion. One stent strategy could avoid complex procedure, long procedure time, multiple metallic straws accumulation at the site of bifurcation. However, the provisional strategy might face some challenges, especially when the bifurcation anatomy is a little bit complex. Several potential mechanisms could lead to increased risk of side branch compromise, such as plaque shift, thrombosis, dissection, and extended hematoma. Therefore, the prediction of side branch occlusion is getting more and more crucial. In 2015, Professor Do Kefer presented an interesting investigation to build up an QCA-based angiographic tool for risk prediction of side branch occlusion in coronary bifurcation intervention. And in 2016, the same investigation group presented a simplified version, V-resolve score, with visual estimation and 4 parameters: pre-procedural diameter stenosis of the bifurcation core, bifurcation angle, diameter ratio between main vessel and side branch, and diameter stenosis of the side branch before main vessel stenting. The V-resolve score greater than or equal to 12 points represent high risk of side branch occlusion. However, the concern is raised that in this study, the majority of the side branch occluded did not have a protection wire placed at baseline. And a simple wire placement could help to restore normal flow and avoid side branch occlusion. And this concept is further validated by recent published data from Korea in 1,890 patients with bifurcation lesion who underwent the one stent strategy were classified into two groups according to the use of side branch wild jailing. And after multivariable regression analysis, wild jailing is a protective factor of the side branch compromise, especially in main vessel stenosis greater than 60% before stenting. However, if we look at the absolute number, even we perform wild jailing, the incidence of the side branch occlusion is still high when main vessel is relatively severe diseased. Therefore, we should figure out some other effective approaches to protect side branch when the anatomy of bifurcation lesion is more complex. So far, we have several options to do active side branch protection, including jailed balloon technique and balloon stent kissing technique, jailed microcaster technique, and even two-stent strategy. And in CIT Resolve trial, the investigators tried to compare the active side branch protection versus conventional approach in reducing side branch occlusion in high-risk bifurcation treatment, defined as V resolve score greater than or equal to 12 points. And the active side branch protection included elective two-stent strategy for large side branches and jailed balloon technique for small side branch. And eventual approach was provisional stenting for large side branch and jailed wire technique for small side branch. Finally, and the patient in the active side branch protection group have a significant lower rate of side branch occlusion. And to further comprehensively investigate the difference between active and conventional side branch protection strategy for coronary bifurcation lesion, we conducted a meta-analysis, and 1,174 patients from 4 randomized controlled clinical trial and 1 observational study were included. And the majority of the patients have true bifurcation lesion, and the active protection strategy included jailed balloon, BSKT, jailed Cosell technique, as well as elective two-stent strategy. And the control group was jailed wire technique. And the endpoint is included side branch occlusion, a decrease in TME flow grade in side branch, absence of blood flow in side branch, per procedural myocardial infarction, and the long-term MACE. And the side branch occlusion was defined as any decrease in the TME flow grade immediate after the main vessel stent implantation. And after analysis, we can see active side branch protection could decrease the risk of side branch occlusion, but not absence of the TME flow in the side branch. And for per procedural myocardial infarction and long-term MACE, the difference between the two groups was not significant. And although the current meta-analysis have several limitations, and there is still indication that active side branch protection approach may have to reduce the side branch compromise in bifurcation lesion treatment. And the active side branch protection provides more chances to restore flow when side branch occlusion occur after main vessel stenting, especially by a jailed undersized balloon and with appropriate inflation pressure when necessary. It could have to facilitate rewiring the side branch to perform further provisional procedure. However, when we do active side branch protection, we should be cautious when jailed device trapped in severely angled and calcified bifurcation lesion and increase the risk of main vessel stent deformation and other acute complications. And routine active side branch protection could be time-consuming and increase the medical cost, and it might only be applied for patients with high-risk bifurcation lesion. And in summary, side branch protection strategy depends on carefully pre-assessment for before PCI. Complex bifurcation with high risk of side branch occlusion needs more active side branch protection. And further investigations are needed to validate the value of active side branch protection in large-scale clinical trials. Thank you for your attention.
Thank you, Dr. Zheng. My question is, in your clinical practice, in what in which percentage of bifurcation lesion do you perform active side branch protection instead of put a conventional gel-led wire? The proportion.
Okay, thank you for your question. It is very important, and for the bifurcation lesion PCI, in my opinion, maybe 20 to 30% of patients, we have to perform active side branch protection strategy. And if we look at the CIT resolve, and if the V resolve score greater than or equal to 12 points, if the angle is larger and the pre-dilation stenosis of both side branch or main vessel is great, or even maybe 60 to 70%, and we have to do more active protection to avoid some acute occlusion complication. And if there is not a complex one, I think just well drilling or even just do the one stand strategy is enough, I think.
Okay.
If I can ask, sorry.
This is a high proportion. Yes, please.
How much is the percentage of double stenting kissing in this by starting of the study? Because this is very important. We have already many studies done by Shaoliang Chen and other study in Europe that when is complex, by definition 2 or more, the side branch, if you use a double stenting technique, you have better result. When it's short, also EBC main, we know already that is best the provisional. So for me, which is the percentage in your study of double stenting kissing? And another thing, how many are double stenting bailout? And these are how are accounted, in which group are accounted that double stenting so complex main branch protection or just fail simple protection? Thank you very much.
Thank you for your question. And in my meta-analysis, only one clinical trial, it's just the CIT resolve, have the active side branch protection involves 2 stent strategies, only one. And if you look at the subgroup analysis, the difference, between active versus conventional, the difference significantly not driven by the big side branch using 2 stent strategy and versus maybe jailed balloon strategy, because the most difference is driven by some small side branch protection. It's only jailed wire technique versus jail balloon technique. So I think the percent of the 2 stent strategy is not dominant. I think for the, in this meta-analysis, the most active protection for the side branch is just a jailed wire and a jailed balloon. It's not a 2 stent strategy. And I think in the clinical practice in China, I think more and more bifurcation PCI is not double kissing or any 2 stent strategy. And the provisional strategy is the dominant one. I think more and more.
Okay. Comments from the panel? Question?
Just one comment. I think we must agree with that there is if there is less stents put in patients, then probably that's better for the long term. But we also have to take into consideration that if upfront 2 stent strategy is planned, that is because that's a very high risk and very complex bifurcation lesion. Or you don't have time, or as we just discussed before, that there are some credentials or then some parts of the bifurcation that you would not like to lose, or either the main branch or the side branch. So I couldn't agree more. we need to divide those patients into different groups of potential loss of side branch or even the main branch. So we have to have, or maybe it would be better to have some values or maybe IVUS or OCT criteria for just guiding the treatment or the treatment plan for the bifurcation. That would be very good.
Okay. Okay, we have to move to the next presentation, the Sepal technique, a novel technique for unjailed side branch guide wire that will be presented by Carlos Uribe. It's a pleasure to have you here, Carlos. The first presentation in person.
Thank you very much. It's an honor to be here. Thanks a lot for having invited me. So the presentation that I'm going to give is about an old technique, a novel use for an old technique for unjailed trap guide wires. So the Sepal technique is an old technique described for treating osteal lesion in 2011. Also known as the floating wire technique. Most of you know that name. And what we have found is that despite this technique is useful for placing osteal stents, we found that we can use this same technique for preventing the deep guide catheter intubation when proximal stents are placed, especially when we need to retrieve the guide wires, when we need to pull the guide wires. So as I mentioned you before, this technique was intended for only precise osteal treatment for precise stent delivery of the stent. As you can see here in this demonstration of a osteal lesion of the left main, and this is in the other graphic, you can see the intended use for this technique, which was only for more precise placing of the stent. But as this is the first description of this technique, which is called Sepal wire technique. This technique, as I showed you before, I forgot to explain that to you, is to place an additional guide wire floating in the aorta while the two guide wires are in place in the coronary tree. So this technique was described in 2011. This is the first description of this technique. And as I mentioned before, was intended only for precise osteal positioning. And this is the result of the 2014 analysis showing that this technique is a proper technique for osteal positioning, for osteal lesions. However, we found that this technique is also very useful for retrieving guide wires which are trapped or jailed when we put a stent, as I depicted here in this horrible graphic that I made. I'm very terrible at drawing, excuse me for that. But the idea is that this there are three guide wires, one which is trapped or pinned between the artery and the stent, and is the jailed guide wire. The other one is the main vessel guide wire, and the other one is the Sepal guide wire. So the idea is it helps when you pull through the guide wire, even though we have taught in our residency that if you keep tension in the guide wire, you manage to avoid to get the guide catheter sucked in the artery. However, there are sometimes places where this is not so secure, and you end up going with the guide catheter going deep, and
damaging the stent and damaging the proximal part of the stent, or even dissecting the left main, or even going very deep inside, deep into the artery and causing damage. So with this technique, we have found that the guide catheter prevents to be sucked in, and it is very well positioned in that way, and it's very stable, and avoids the catheter to get sucked in when we try to pull the gel guide wire in the side branch. So we recommend a third guide wire. We recommend along the way, we have found that doing it with a extra rail guide wires is better. For example, the Grand Slam guide wire or the extra support guide wire because of the pulling force and the contrary force that the guide catheter placed on this place. So it's better to have a better rail guide wire. So there's definitely a need for better control and safety when unjailing side branch guide wire, especially in the techniques that we're using today, where the pot is a required step today, and which pin harder the guide wire to the vessel wall. And this is particularly true for calcific bifurcations, where pulling force for unjailing the guide wire might be excessive. So this is the case number one that I'm going to show you. We have performed 34 cases by now, and we are planning to do a publication ongoing. And as you can see in the let me see, show you again in the second larger, you can see that we pulled, the guide gets still there without moving inward. This is another example. As you can see, the catheter tries to get sucked into the artery. However, the third floating wire avoids the catheter to go further into the artery. So this is the final result, showing you that the left main is with no damage, and the other places of the artery is with no damage at all. So from our experience, this technique has been shown to be safe. This is a case where we have a transient prolapse of the guide wire of the floating wire. Let me show you again. As you can see, the floating wire got into the artery. However, these have no complications, as you can see here in this final, and the final result is great. This is another case. This is our fourth case done, and as you can see here we are now trying to pull, and the guide gets perfectly well seated there in the aorta, and there is no damage after all in the final place. This is another case, and as you can see again, we are pulling traction, and the third guide wire, as you can see here, the third guide wire is doing his job. This is another case. This is the final result, excuse me, and this is the depiction of a stent boost showing the stent which is indented and not touched by the tip of the guide wire. This is a left main case that we have done. Distal left main case, also perfectly done with this technique. And this is the final result, showing you that the stent is perfectly placed with no distortion whatsoever. This is the final result, and the stent boost of the technique, showing that there is no interaction between the guide and the proximal part of the stent. This is the final case that I'm going to show you. This is 2 bifurcations that I have done in one patient. This is the technique again in action. Okay. In this case, we only have 2 wires. We learned along the way that it's better to have 3 wires. We did this case only with 2 wires, but the idea is to have 3 wires in order to avoid this, what did just happen, which is you lose the proper place for the guide into the proximal part of the left main. So it's better to have another guide wire into it. This is the circulation of the patients, and again, showing you that there is no interaction. This is the final result, which is show that there are no complications with this technique. So as a conclusion, Sepal technique provides a safer and controlled way to unjail side branch guide wires, easy to perform, cheap and reproducible, avoids unintended, uncontrolled deep guide catheter intubation and its related complications, let's say dissection, longitudinal stent compression and distortions, and a paper describing this particular novel use in bifurcation is under submission, and a registry is underway to prove that the use of cephaloplasty devices is safe. Thank you very much.
If I can say something, of course, this technique is more important when main proximal branch is of the same diameter or not too big of the main distal branch, because otherwise the difference between is make less danger on the jailing of the side branch. So maybe it's more useful when after pot than before pot. This is my comment.
Yes, what we usually do is to retrieve the jail guide wire after pot, you know, and not before pot, because what we do is to have the side branch guide wire as a marker for the other guide wire, you know. So, yeah.
Carlos, do you use this technique in our case of jailed wire, or only in a provisional way when you note some resistance to the retrieval?
Mm-hmm. When we know some resistance, definitely. Mm-hmm.
Carlos, thank you for the presentation. Did you ever think about just using the 035 wire instead of taking a third guide wire, to just place the 035 wire from that you've on the table and use that as a wire in the sinus, because it will give you more support and will allow you to back up your guide more?
Yeah, you can do it with also with an 035 guide wire, let's say an hydrophilic standard guide wire for radial approach. You can do it, but you know you are with a going through a 6 French, so it's not so easy to pass a 035.
This technique, it appears that it stabilizes the guiding cath more, and unjailing is easier. But what happens in the very complex cases when you are doing like the crash and you have so many repeated inflations? Did you encounter some difficulty in having a third wire with all these equipments inside?
Mm-hmm. Yeah, that's one of the issues. I mean, that's one of the issues. But as long as, I mean, if you are working with an 014 guide wire, there's no problem at all to have a fourth inside the guide. So, it's a balance, But for me, it's better to have safety. I mean, it's to have better control and not end up with a longitudinal stent distortion in complex cases, especially with left mains, proximal left mains or distal left mains.
Just one more question.
We have not time. Please, very short. No, short question.
Just one question. Answer, was there, after pot, leaving the wire in jail, did you experience any breakage of the wire or just losing part of the wire in the side branch? That's just one part of the question. And did you consider using hydrophilic wires? That's easier to pull back even without the third guide wire?
Okay, yeah, the reason that we put we leave the guide wire when we do pot is because the pot allows you to have a better cell. You know, the cell of the side one, one of the cells of the stents get better protruded to the side, so it's better for you to recross after the pot, recrossing guide wires after the pot, you know. So for me, it's always the standard technique to leave the side branch and leave it after the pot. Because if we are thinking in maybe recrossing, it's better for me if I have pot and then doing the recross, knowing that I have done pot and the struts are now placing more through the side branch, you know. So a standard for me is to retrieve the guide wire after the pot, to retrieve the jail guide wire after the pot. This is the standard procedure for me.
Okay, thank you, Carlos, and congratulations for your presentation. For the next, it's for me a pleasure to introduce the next speaker. This is Yoshihisa Kinoshita. He's a friend, a great operator. He was in Cordoba in our center last week performing an incredible case, very complex, with success. And he's going to talk about the real jab technique, solution for side branch occlusion. Yoshi, whenever you want.
Yeah, thank you, Manuel, and thank you, ABC members. Today, I would like to talk about the new better technique for the side branch compromise. Okay, this is my your slide. And although we usually follow the keep it open concept for the side branch stenosis, but some kind of intervention to side branch is necessary in advance for a region where side branch compromise is anticipated during the treatment of the main branch. In such cases, dissection may occur in the side branch ostium, which may cause difficulty in recrossing the wire. The real jab technique, which means rewiring to the dissected side branch along the jailed balloon, is a technique to ensure that the wire passes into the dissected side branch. Yeah. Okay, this is my first case. First case is 80s male and LADCTO region. After passing, this operator is my young colleague, and he passed the wire and putting stent from the mid part to the distal ready, and he directed the first diagonal branch with 2 balloon to avoid its obstruction after the stenting in the main branch, and then he put the stent. He put the stent and at approximately using the gel balloon because he tried to avoid the side branch. And yep. And after removing the gel balloon, he could not. He tried to recross the wire to side branch, but he couldn't do that. Due to maybe dissection of the side branch ostium. And in this situation, operator changed to me, and I tried to advance the wire into the side branch, but in the same situation occurred. I could not pass the wire because in my tactical feeling of the wire, that way is a very I feel the very big dissection. So. We are stuck and I'm in trouble, but at that time I came with a new idea, came out a new idea for me, and so once, just a moment, yeah. So once again I insert the balloon outside from this stent using this protection wire. But at that time, I felt a little bit resistance because of this stent, implanted stent. So certainly I use the anchor balloon technique. Using by the anchor balloon technique, it is easy to advance the wire to the, this side branch. And then I direct this side this balloon, this two balloon again, and in this condition, I advance another wire, and this wire, and I pressed another wire from the main branch in the contact with directed balloon, and advance the wire into the diagonal branch by running it along the surface of the balloon. And immediately after balloon dilation, okay, this one. After balloon dilation, deflation, yes, I advance the wire just so like a stripping on the surface of the balloon catheter. So I can get the this so dissected. I can pass the wire through this dissected side branch osteum. Yeah, and finally I do the drug eluting balloon at the osteum of the diagonal branch, and final kissing balloon also I performed, and this is the final result. This case, second case is 80 female. She had, as you can see, already under the severe stenosis in the LAD and at the LAD and diagonal, first diagonal bifurcation 011, like this. Yes, and in this case, so the diagonal, it's a little bit difficult to see, but this is there is a very severe calcified region around this bifurcation. So in this case, I thought that when I put the stent in the main branch, the Calenici may be occur. The Calenici maybe this diagonal branch occurred. So first I dilate this diagonal, but as you can see, this diagonal, stenosis of this diagonal is a little bit stiff because of calcified plaque. But after the remove the indentation, as you can see, we can see the little bit small dissection here. So in this case also, I use the gelled balloon technique and put the stent in the left, in the LAD. And in this case, I didn't pull out this gelled balloon. I pressed this gelled balloon, and then as I performed the before case, just once again. Sorry. Yes. After the deflation of the balloon, I advance a wire along this balloon surface. Yep. So it is easy to advance a wire. And this is the final result. As you can see, also this case also I used the drug-coated balloon in the diagonal branch osteum, and also I add the final kissing balloon. As you can see, there is a little bit dissection at the side branch osteum, but we can keep the Timmy-tree flow in this case also. Yep. So once a dissection occurs in the side branch osteum, the wire is often trapped in the dissection space and may not recross successfully. And in this situation, stent further restrict the behavior of the wire and make it more difficult to recross the wire into the side branch. The principle of the real job technique is to close the dissected space and temporarily dilate it, the true lumen by the dilation balloon, and to advance the wire along the surface of the balloon for the remote wire navigation. This is very similar with the reverse cut technique in the CTO region. Yep. So this is my conclusion. This technique is useful in the treatment of true bifurcation lesion when recrossed wires in complex situations where there is a potential for side branch occlusion. Thank you for your attention.
Thanks, Yoshi. Questions? Short question, please, because we have no time. We have to finish the session right now.
Just one comment. I think sometimes it could be a good technique, but you have to be lucky to perform that. But we have to consider putting stents in dissected side branches. But that's just one comment, that I would be afraid that for the long term, that the side branch would be kept open, leaving such dissection in both cases.
Yes, thank you for your comment on the question. In this, until now, we usually use the DCB after the dissection of the side branch ostium, and many side branches you can keep it. You can keep it.
What type of wire do you use to recross with the balloon? Do you use a workhorse wire or like a Gaia type wire when you're trying to puncture back in?
No. Second, usually we use the Sion block as a second wire. Okay. I recommend you, if you want to use this technique, the polymer jacket wires are better. Polymer jacket covered wire, like a Sion blue, or if you feel some resistance stiffness, at that time, Gladius is better.
Okay, thank you, Yoshi. The next presentation is a very severe complication that can occur from it's not frequent, but it's a problem in the lab, and is going to present by Sinjini Biswas. It's a case of a rupture of a yellow side branch. Sinjini? May we have the presentation?
My name is Dr. Sinjini Biswas. I'm an interventional cardiologist at the Bristol Heart Institute in the UK, and I'm very grateful for the opportunity to present this case today, which I've titled Getting Out of Jail, but Not in One Piece. This is a case of a 67-year-old gentleman who presented to our institution with an anterior STEMI. He had minimal cardiac risk factors, and in STEMIs I usually take a shot of the non-culprit vessel first, which is shown here, and that shows a large dominant RCA that has minimal disease. On taking shots of his left system with an EBU35 guide, it was clear that he had a severe ostial circumflex lesion, but it was actually his LAD that was the culprit vessel, with thrombus evident at the level of the diagonal branch. And after wiring with a cyan blue and pre-dilatation, I deployed a 3.0 by 24 synergy stent in the proximal to mid-LAD, with the results shown here. After post-dilating the stent with 3.5 and 4.0 NC balloons, I then undertook intravascular imaging with IVUS to make an assessment of the acute stent result and assessing the LAD ostium for future procedural planning. This actually shows relative freedom of disease of the ostium of the LAD and a reasonable acute stent result in the mid-LAD. Given that treating the ostial circumflex would necessitate stenting back to the left main, I decided to stop at this stage and to discuss him at the MDT, where it was felt that with isolated ostial circumflex disease, it was reasonable to treat this lesion percutaneously rather than with a surgical revascularization strategy. So I arranged for him to come back 2 days later with a plan to undertake a layered provisional strategy to treat his left main into the circumflex and then to consider reopening the struts into the LAD at the end. So I took a 7 French EBU35 guide, wired the circumflex with a cyan blue and the LAD with a turn track wire, which are the two main workhorse wires which we have in our lab here. After pre-dilatation to create some space, I undertook an IVUS assessment of the left main to the circumflex. You can see here that the left main is quite large at 4.5 to 5 millimeters, and the proximal circumflex itself is quite big at 4 millimeters. I haven't shown you the IVUS of the lesion itself, but it showed a soft plaque with no significant calcification. So I took a 4.0 by 16 megatron stent for purposes of its radial strength from the left main to the circumflex. IVUS shows the left main ostium is healthy, and so we purposely chose not to extend the stent back to the ostium. And so this is the immediate post-stent result, where the LAD ostium appears pinched, and so the plan was to rewire into the LAD, open the struts, and do a kissing balloon inflation. But before doing that, to overcome the differential in size between the circumflex and the left main, I did a pot on the left main with a 4.5 NC balloon, and on this clear stent image, you can see the interventional wire the pot balloon is on, and the wire that is jailed into the LAD lying under the stent. So at this point, I took a fresh cyan blue wire to rewire into the LAD through the Megatron stent, and then wanted to take the jailed wire out. However, on pulling the jailed wire, I couldn't feel any resistance, I wasn't pulling hard, and the wire was coming back out of the TUI, but I couldn't see the tone track tip move back on the screen. So my immediate worry was that I'd damaged the wire and that it was perhaps unraveling, and so I called for help with a colleague, who then scrubbed in. Took a 1.0 sapphire balloon down the wire with a view to burying it under the stent and pulling the whole thing out as a single unit. But what became quickly apparent was that as Tom pulled more, this came out. And essentially the wire outside the body was detached to the segment of wire in the coronary. So, what do we have now? We know we have a stent in the circumflex back to the left main and an interventional wire. We know we have a jailed wire behind the stent into the LAD that's broken somewhere, but what we don't know is where it is fractured. Has it done it somewhere back in the guide, like option A? Do we have a wire that's fractured at the point of the edge of the stent? Do we have a wire where the back end is hanging somewhere in the aorta? Or do we have a wire embedded deep somewhere behind the stent that just extends out to the distal vessel? And the next question then is, how has the wire fractured? Is it a sharp fractured end? Is a single filament that's coming out? Or do we have multiple filaments coming out of the wire? And so it is this point where imaging was very useful, and you can see some incredible images of these multiple filaments just sitting in the lumen of the vessel on this IVUS. And moreover, when we came to withdraw the IVUS catheter, it becomes evident the IVUS catheter has managed to extract quite a lot of this material. So it's all caught up in the V angle between the IVUS monorail and the guide wire. We pulled all of these filamentous material out. And so we did that a few times, and every time the repeat IVUS images showed fewer and fewer filaments. And every time we got out all this hair-like material caught between the IVUS and the wire. And so we thought that's a win. And then we did the IVUS again, and I've truncated the run, but hopefully you can see that there are still some filaments in the left main, and filaments going back into the guide, which I've just highlighted here. So now we have confirmation that the wire has definitely fractured somewhere in the guide. What are our retrieval options now? Well, firstly, we could snare it out. However, it would be likely to be challenging to cross with a snare through the side of the left main to circumflex stent struts into the LAD. And we need to consider that this is a recently implanted mid-LAD stent, which could be damaged or dislodged with a snare. Furthermore, the jailed wire tip is located very distally, and even if we did manage to get hold of it with a snare, it's unknown how the wire would behave when retracted given it's behind the left main stent. The other option would be to snare proximally. This also carries the risk of dislodgement of the fresh left main stent, and the degree of wire integrity between the visible tip and the guide is actually uncertain. But we decided that we'd have a last-ditch attempt at taking a microsnare to mop up some of the stuff at the front end, in the left main, but actually it didn't bring much material out. The other option that we thought was we could trap it out. So we could trap everything in the guide and take everything out, but then we'd lose all our wire and guide position. So before we do that and lose all our wire positions, we decided to optimize the distal left main bifurcation with kissing balloon inflations. We then used a trapping balloon in the guide to bring it all out, but that actually didn't bring much material. But what we didn't notice at this point in time is that the wire tip that was very distal has actually now come back much more proximally if you compare the two images on your screen. So now we have no guide, no interventional wires, a left main to circumflex stent and a mid-LAD stent, but a stuck wire tip. And our options were now just left to stent the proximal LAD and cover up whatever's left behind, or try and retrieve a bit more. But if so, how? We made the decision to go with option 2. Now that the fractured wire tip was clearly more mobile, we thought it would be worth making an attempt to remove it all via a snare. So, how can we snare safely? We went back in with a 7 French GBU35 guide, rewired with a cyan blue in the LAD, ensuring on IVUS that the wire is not abluminal at any stage, and then took a 6 French guidezilla over a balloon to go into it, and through the side of the left main to circumflex stent into the LAD so that the guide extension is now at the level of the wire tip. And we've simulated this on the right on a benchtop model as well, which you can hopefully appreciate the guide extension catheter moving forward. We then took the microcatheter that comes with the gooseneck snare down out of the guide extension catheter, as you can see on both the simulation and the angiogram. We then catch the tip of the wire through the microsnare, and as we pull, the forces are applied around the tip of the guide extension and not then potentially shearing it around the left main stent and damaging this fresh stent. And you can see here it all comes back in this absolutely wonderful moment after many hours of fighting with this wire tip, where the gelled wire involuting around the tip of the guide extension catheter. We hope that most of it is now gone, but IVUS shows one or two filaments hanging around, and so we complete an extended culotte to cover it from the LAD back to the left main ostium. So stented the proximal LAD back to left main with a 40 by 28 synergy, did a pot on the left main with the 4.5 NC balloon, recrossed into the circumflex with a cyan blue, and opened the struts out in the circumflex with a 2.0 balloon, and then did kissing balloon inflations with a 4.0 NC in the LAD and a 3.5 in the circ. And so this was our final result in the LAD angiographically and also on IVUS, which we were really quite happy with and thought it was quite a reasonable result from where we started. So what are my learning points from this case? Firstly, guide-wire fracture is a rare complication. There are several risk factors, including tortuosity, calcification, forceful pulling of a wire, and having jailed wires. It's important to be familiar with techniques to remove fractured guide wires, some of which I've illustrated in the case and also in the cartoons on the right. As was illustrated in this case, imaging is fundamental to understand what is happening and to tailor the technique that you use. And finally, in a complication, stay calm, think systematically through the options, and use your colleagues to help you out, especially earlier in your career. Thank you.
Please, short question. We are 15 minutes late, so
it was an outstanding case, and very brave, and we congratulate you for such a wonderful success.
Okay. Okay, we move to the next one, to the last one, about rotablation. Opens the pathway toward provisional for Alexandru Achin. May we have the last presentation?
Good afternoon. My name is Alexandru Achim. I'm a cardiologist from Cluj, Romania. And although I'm the last one to show you my case, I hope to catch your attention with, I would say, an interesting left main bifurcation case, which actually we did together with Gabor Tot while he visited us back in the spring in Cluj, doing this case together with the doctors from there. So the case is about a 73 years old female with the usual risk factors presenting to our service with severe unstable angina. I don't want to insist too much on the clinical data due to time constraints, so I'm going to jump right into the moving scenes of the coronary angiography, where you can already appreciate the distal left main lesion. I would say it looks like almost like a huge calcific nodule protruding inside the polygon of confluence, mostly onto the left main circumflex shoulder. The proximal LAD angiographically looks very calcific, but not very tight. So I would say this is a Medina 101 lesion with a dominant circumflex and a huge left main caliber. From the cranial view, you can see that there's also lesion inside the mid LAD, and you can appreciate again the severe calcifications throughout the whole coronary system. So once again, the distal left main lesion, which actually it's like a calcific nodule, which is not very regular. It has also like a spike on top of it, which we predicted it will give us a hard time at least to wire the circumflex, if not to keep this case to a provisional strategy rather than going upfront to a two-stent strategy. So back then we thought what to do with this case. Also, I don't want to talk too much about the indication. This case was refused by the surgeon, so we had to somehow to find a solution for the PCI. Should we rotablate upfront? Can we do it only with the balloon? But if we do it with the balloons, we need the wire inside the circumflex. can we put a wire inside the circumflex? Even if we put two wires and we start ballooning the bifurcation, we will have a huge plug shift towards the circumflex. And is this a good idea? Can we stick to it with provisional if we do such a huge plug shift? So in the end, we thought about going upfront rotablation with the 1.5 per and somehow stick to the provisional philosophy and strategy along the way and see if it's possible to finish with it. Like we predicted, we tried like 20 minutes to wire the circumflex. This was not possible. The operator tried various wires, various microcatheters, dual lumen microcatheter. It was not possible to wire the circumflex. The wire was always protruding inside the LAD. So in the end, we put the rota wire inside the LAD, and we, in our imagination, we thought about shaving at least the head of the nodule, and this way maybe we make a bit of space, and after this the wiring of the circumflex will become a bit more easy. Unfortunately, this was right, so we could wire the circumflex after doing rota towards the LAD. This is like the final run of the rota, but I must say this took like 10 slow, good runs of rota until we obtain this result. So you really have to have patience if you want to rotablate such a huge nodule of calcium. Surprisingly, this was the result after doing only rotablation towards the LAD and towards the left circumflex. I would say this is a pretty good result, but of course you need to put higher balloons to make sure that the lesion is cracked and you can safely deploy a stent. But before that, we used IVUS in order to assess the diameter of the left main, and indeed the proximal diameter of the left main was 7 millimeters and looked rather healthy. So we thought about not covering the whole length of the left main because of its huge diameter, but try to stick to the disease part where the plaque was and somehow land intentionally inside the plaque, or at least only a bit outside the plaque, in order to not obtain a severe malapposition in the proximal left main. We did a pot with the biggest balloon we had on our shelf, which is a 6 millimeter balloon, which we inflated it to a maximal high pressure in order to obtain even higher diameters, to make sure that we obtain a malapposition, as this is very important. We also did kissing and then repot. Fortunately, we obtained an apposition at 6.3 millimeter, which really is its maximum. It's the maximum diameter where you can overexpand your stent. So this is the result after our pot, kiss, and repot, which angiographically and also on IVUS looked very nice. Somehow the calcific nodule almost melted, so it disappeared, and this is the benefit of rotablation, and not because of the ballooning. So this is our final result. We also stented the mid LAD. So in conclusion, what rotablation allowed us and what we learned from this case is that doing rotablation firstly allowed us to do something very basic, to wire the circumflex. It was not possible to do it without shaving our nodule. Second, it allowed us to keep our most diseased branch and as the main branch while doing our provisional technique along our PCI. Third, because we didn't balloon the bifurcation before doing the debulking, we did not have a huge plaque shift towards the circumflex where the nodule was sitting, so potentially losing it and overstretching and dissecting the bifurcation. So we really obtain a clean bifurcation by only doing debulking with the rotablation. In the end, of course, rotablation helped us to finish our strategy with just one stent, which is really great. In the end, I want to thank you, and this is how rotablation opened and kept our pathway to our provisional technique. Thank you very much.
Unfortunately, the presenter is not connected, so we have not question. We have to finish this interesting session with the following conclusion. In case of difficult side branch wiring, use all the classical technique. Reshape the wire, use double lumen catheter, use dedicated microcatheter with defectable tip. The use of the yellow wire for only for complex bifurcation, that was one of the conclusions of the presentation of this session, will be discussed in our next EBC consensus. I think it's an interesting finding, but seems to be discussed. Active protection of the side branch seems to be more effective than the use of a simple gelled wire, but complicate a little bit the procedure. In case of dissection of the side branch, the jab technique seems to be a useful technique, as Dr. Kinoshita has shown. If you note some resistance, when you remove the gelled wire, you can use the Sepal technique that probably avoid a complication in the left main, in the ostium of the vessel, or in the deformation of the proximal stent. And finally, rupture of the gelled side branch is a very infrequent complication, but be prepared to be treated with a microsnare. Thank you for your attention. Thank you for your comment, and have an excellent meeting.
Bye.
Thank you. Bye.
Okay, so we have these complication sessions. We have many cases submitted for this case session. We selected 5 cases. They are very interesting, and then I assure you we appreciate the discussion also of this. It's not, you know, you should have the courage to sometimes to submit your errors, your mistakes, and we can learn from the other mistakes and avoid to do the same mistakes in the future. I want to introduce the first, my co-chair is Jens Lassen, which is here, and then you have Francesca Sanguinetti, which is the chair, and then we have a panel of Dukan Din, Luc Malar, Stephen Mott, I excuse if the pronunciation is not correct, but Josica Sishik, Hamid Reza Sanati, Amit Sangvi, and Okan Tagut. So it's we can start with the first presentation from Ina Kazianova, and the name of the presentation is Non-Standard Complications Require Non-Standard Solutions.
Hello, everybody. It's a great honor for me to be here and present you our, as I think, very interesting and not so easy case. Not standard complication required non-standard solution. The patient was quite standard, 60 years old female with no obese, with stable angina class 2-3, without history of previous myocardial infarction. Ejection fraction was preserved, 58% with slight sign of anterior hypokinesia. Rest ECG was normal, baseline level of creatinine was also normal, and she had strong family history. Her youngest brother had severe coronary artery disease with first presentation as acute myocardial infarction at the age of 47 years. At the coronarography, you can see the how I can move it. We find significant lesions in. How to move it.
Yeah, can someone make the
okay, we find significant lesions in left.
Just to see.
Switch, but it next.
Probably someone have to click on the image.
Can guys help me?
Yeah, with the mouse
probably. Okay. We find significant lesion in the proximal part of LAD, and as we decide, significant lesion at the first diagonal big branch. At first glance, these and no lesions in the right coronary artery. At first glance, it didn't look like a bifurcation situation and didn't require any difficult bifurcation procedure. That's why plan was to implant two independent stents, first to the diagonal and second to the LAD. First was performed direct stent into the diagonal branch without protrusion to the LAD. After that was performed rewiring, predilation in LAD, and long drug-eluting stent 3.026 millimeter was implanted to the LAD. But when we inflate the stent, we see the place of very short area where stent didn't expand. We perform a few times post-dilation with short high-pressure balloon, but it didn't help to resolve this situation, and we perform stent enhancement study, which revealed, sorry, it doesn't move, it's just a picture. This is done video. Stent enhanced study revealed short stent stenosis at the place across the ostium of diagonal branch, and IVOS was performed at this area and revealed 2 stent layers at the place of origin of diagonal branch. And at this moment we decide to stop and to find something good solution for this patient. And maybe who can, what solution you choose? For making decision, we decide to explain herself, myself, what situation happened. And in this picture you can see what the alleged cause of this situation. Wire and stent crossing protruded diagonal stent, and it can be reason of limited space to full LED stent expansion. At this moment, we stop. Our patient didn't have any complaints. We didn't find any blood flow limitation, no ECG changes. That's why we stop at this moment. And in few days, our patient was discharged with aggressive double antiplatelet therapy. We used ticagrelor and aspirin. But she had strict outpatient follow-up. 1 time a week she come to the hospital and we check with ECG and just anamnesis. In few months later, our patient come back with persistent angina, recurrent angina, and we perform repeated coronarography, which revealed significant proximal progression of atherosclerosis, significant stenosis at the ostium of LAD. At the first coronarography, this area was unaffected, and the stent construction was at the same state that was at the end of the first procedure. We perform repeatedly high pressure balloon dilation, but it didn't resolve situation. That's why we have prescribed scenario for this situation, and we perform next, and we decide to perform rotational atherectomy at the place of unexpanded stent. We used 1.5 millimeter bore with no high speeds. No any difficulties was with putting wire and putting the bore, but after 3 rotablations, high pressure balloon was inflated and was explained full without any problem. You can see it, and we receive good picture, but we understand that we have broke stent at the place of previous stenosis, and we have significant lesion at the proximal part of LAD. The stent expansion was confirmed by stent enhance, and we put another long stent which covering new lesion and damaged video, please, which covered broken stent and new lesion at the proximal part of LAD. The final result was good. We was satisfied, and patient didn't have any complaints and was discharged. And in conclusion, I want to say that in any case of any complication, you need to understand the nature of this complication to find the optimal way to solve it. Stent ablation with rotational atherectomy can help to manage the underexpanded and underdilated stent, but long-term results are not so good and not so acceptable sometimes. And non-standard complication required non-standard solution. That's our case.
Thank you for this presentation. I have some question. I put some question. What type of complication is this? So first question: which type of stent you implanted in the side branch? Which brand of stent? Resolute Onyx. And the diameter? 2.5. So first of all, you should know your stents. Now the Resolute 2.5, which is a maximal expansion, and you should know that the Medtronic made a modification of this stent because it's not a 3 connections, so they put more cells in the proximal 1 millimeter. So if you engage the cell, which is very close to the other, the expansion of this cell is impossible to reach the other part of the vessel. And Murasato presented a case report similar to this. He published in Eurointervention last year, and it was the napkin ring complication because you are unable. So you should know which type of stent you implant, and also the size, because sometimes a 2.5, for example, Medtronic has not the same expansion as 2.5 of other brands, which have the first stent. So if you know your stent and you have this, you recognize immediately that there is this protrusion, and then the wire is through, and you could avoid to overexpand the string and just do a crash the stent, convert in a crash. And the other question I want to ask you: how was the feeling? Because you didn't expand this side branch stent, you crossed with the other stent directly. You did some ballooning.
Performed predilation at the LAD, but we didn't have any difficulties to put the balloon to cross the. That's why it was unexpected, because we have no difficulties with rewiring and balloon.
And the other comments that I have is why to use rotablator, because you rotablated the LAD, not the other stents. So it's so probably the rotablator didn't do anything. It was the high pressure that you used in the follow-up that was able to rupture the ring that was in the other side. And maybe it was not a complete rupture because there was some indentation still.
We perform a few post-dilation. At the first procedure, we perform few post-dilation with high pressure, very short balloon, but it didn't solve the problem. At the second procedure, we begin from the post-dilation with high pressure balloon, and again, it didn't work. That's why they decided to use more aggressive tactic, because high pressure balloon didn't help us.
Another thing that you should have in your cath lab is to have balloons that go to 40 atmospheres. Sometimes they are available, and
I think that it can help us, but it's very bulky device, and we have dubs. Can we put it inside or cannot? That's why, and unfortunately, we didn't have it in cath lab.
This is my comment. If you have other comment, yes.
Yeah, thank you for sharing a very nice case. I just have a doubt about the IVUS image that you showed. If the stent has crossed through the proximal most cell of the diagonal, and there is so severe narrowing because the cell does not open because of the connector or the design of the stent, the IVUS would not show such a large. The IVUS picture cannot be like this, because then the inner cell through which the IVUS goes will be very, very small, whereas the one that you showed, the diameter is almost 2.5 of the inner cell, and the outer cell is 3. So where will be the outer cell? If it is gone through the cell, the outer cell you won't see in that same picture, because those two will be fused. You will see two different cells proximally and distally, not at the site of the two cells.
Actually, I don't know. I didn't have many experience with IVUS interpretation in this situation. That's why for me it's difficult to explain, but we exactly saw the two layers of stent. That's why they decide that it's a sort of protrusion, and that's why they interpret this picture like this.
Yeah, I think the napkin ring abnormality that you said is when you recross through the strut. Now, in this case, there was already a wire in the LAD and there's another wire in the diagonal. So why did she have to recross? She didn't recross.
Because we didn't perform bifurcation. We used just one wire. Maybe the best solution in this case to use two wires from the first stage. It solve. We didn't. I understand it now, but at the beginning of procedure, yeah.
And another is to have a balloon-assisted deployment, because sometimes you can have a balloon there. So you did two mistakes: not wires in a bifurcation, and you didn't use a balloon to assist.
Now I understand it, but before procedure I didn't think about it like a bifurcation stent. That's why it was just two simple stents to the two simple lesion. That's why.
One question?
Okay, the last two questions, because
I have a comment and a question. The first, my comment, it's, in my opinion, it's a spike of calcium rather than napkin ring. And I will ask the panelists about the experience in using the root ablation in newly deployed stents.
This is of course a different discussion, but you can use root ablation if you really. Yeah. Of course you can root ablate a stent. We don't recommend it in the beginning because of heating and maybe complications. But if you're in serious trouble, it is possible to do it, and there's several case reports, so it's doable.
The only problem is that when you do use a balloon after rotablation, you have sometimes the balloon rupture, and then you have other complication because because of rupture. You have this.
But just
last question.
Yeah, well, but maybe just to finalize everything, it was an excellent case, and it actually goes back to one of our very first consensus documents, where we said we had difficulties in defining when a side branch was significant, and we discussed that a lot. But we decided to always recommend two wires, because then you would have avoided the complication.
So Remo, as you mentioned, balloon-assisted side branch stenting, we are also stenting the ostia with balloon assistance. So that also has shown very promising results. Balloon-assisted ostial stenting.
Yeah, balloon assisted. Sometimes, if you have, depends on your guiding catheter. If you have a big side branch and you want to use balloon assistant, 7 Frenches for the beginning is well recommended, or a wide guiding catheter. So thank you for this first case. Then we can go on with the second one. Presented by Kristina Marek-Basic. And the title is Less is More.
So, thank you very much. I will show my complication case from bifurcation PCI. So it was a 79-year-old lady. She came to our hospital because of chest pain and STEMI, and that was in 2019. She had a history of arterial hypertension, hyperlipidemia, and a myocardial infarction in 1985, which was treated conservatively. A colleague of mine was on duty, so he did the coronary angio, and there was a diffusely diseased RCA, and also which was the culprit lesion because of the subocclusive stenosis in the mid-segment, and a true LAD D1 bifurcation lesion. So the colleague performed the PCI of the right coronary artery. You can see here that the right coronary artery also has a lesion in the distal part. It's the ostial PD, But my colleague was not so keen to do a complex PCI in this patient, and he decided only to treat this mid and this proximal part with implantation of 2 drug-eluting stents. So the patient came back for this elective procedure on the LAD. You can see here and the diagonal branch, it was 2 months later. I chose the transfemoral approach because I wanted to use a 7 French guide. And you can see here that this is really a big diagonal branch. And the lady was almost 80 years old. I knew that she didn't want to have a long procedure. So I thought, okay, I think I would do a provisional stenting approach. I don't know, we can comment later if somebody would go up front with a 2-stent technique in this bifurcation. So I wired both vessels, and I did the pre-dilatation with a semi-compliant 2.15 balloon, and on the QCA, the LAD was about, the distal LAD, the target was about 2.5, so I planted a drug-eluting stent, 2.515 at 14 atmospheres, and after that I did a pot with a non-compliant balloon, 3.0, and I was obviously not satisfied with the diagonal branch, so I did the rewiring with a whisper wire and did the dilatation of the ostium with the 1.12 semi-compliant balloon and 2.010 at 12 to 14 atmospheres. So this was my result after this pod site, and I thought it was just a nice result. So what would you do now? Would you do now kissing balloons and then repot, and there's also a lesion in the proximal LAD and put a stent? Or would you just be satisfied with this result and say, okay, I keep it simple, I just do a repot and then do a stent proximally? Do you have any comments?
You can do both. You know, in the last, if you want to, you can finish at step 2 if the result in the side branch is good. And
Okay.
good.
Do you think it's a good result in the side branch?
My opinion, yes.
Okay.
It was not, the flow was good.
There was no dissection.
No dissection, no stenosis more than 70%. It was maybe 40%. So,
Okay.
But sometimes the operator can choose to do it. I do systematic kissing, for example. In this case, I go for a kiss.
Okay, I thought also it could be better because I think the diagonal is a bigger branch. So also I would like to use a DCB. So I will go with a non-compliant 2.5 balloon. I will pre-dilatate, then I will use the DCB. And then I will do the repot, and then I stand the proximal part of the LAD. Why not? I think it's a bigger vessel. It deserves a bigger balloon. So I tried to go with a 2.512 non-compliant balloon, but it couldn't pass. Okay. I used a new semi-compliant balloon, a smaller one again, and inflated it at 18 atmospheres, and the balloon ruptured. And then I was very surprised. Why have I a perforation when the balloon was in the bifurcation and it ruptured because of barotrauma, I presume. So there I have now a problem, which I wouldn't have had when I had done only a repot and a stenting proximally. So I took a balloon, now 2.15, and yeah.
It is a distal to the bifurcation.
Yes, very distal to the bifurcation.
You balloon it there?
No, I balloon it in the bifurcation. Distally, I was not there. I was not moving the wire. I was not there with the balloon because
So, it's a wire.
the wire is always no. I think it's because the balloon ruptured and the barotrauma. Yes. No, it's not a spiral dissection. I don't know. Maybe in the balloon there was too much air or something.
Were you sure that you were in the distal strut? Because I see this wire, which is...
I'm not sure I was in the distal
because
strut.
sometimes if you are in the proximal wire, you have this neocarina, and then when you go down with the neocarina, puncture the balloon. So it's very very important to be sure, because this case you see the wire is
a little bit up,
in
yes.
the proximal part.
Yes. Well, I was surprised, and then, okay, I took, now I could pass with a bigger balloon, and I inflated it for about 15 minutes.
This is just to if you have a proximal cross,
Okay.
to recross the stent with any device in the side.
It is very difficult. Yes.
So you have this neocarina that interferes with everything.
Yes.
So remember, the distal cross is very important.
Yes. So I couldn't place a graft, stent graft, and then I used the extension, as you see here, extension catheter, and I was not able to cross with anything. Then the patient was obviously not well. She recovered after atropine and saline infusion, and she complained about the duration of the procedure, and she became restless like me. So, well, I said, well, I have to do something, and I was able finally to implant a drug-eluting stent. And I thought, okay, the extravasation is here, but the echo, we did echo in the cath lab, there was no pericardial effusion. I'm fine. I'll just leave the stent here, and maybe everything will be fine. And then I wanted to stent the proximal LAD, and then some colleagues said, I think you have a dissection of the ostium of the LAD. Fine. Because of the extension catheter, fine. Now I have a trifurcation here. Wow, I have a ramus, a circ, I have the LAD. I don't want to do it now. I just put a stent into the ostial LAD. I think the lady will be fine with it. And it went well. So, this was the final result. TIMI3 in the LAD, TIMI3 in the diagonal branch. There was no contrast anymore, I thought. The echo was fine. There is a slightly dissection in the ostial diagonal, but there is TIMI3 flow. I don't want to go there anymore. And I was happy.
Question, which type of covered stent did you use that didn't cross?
Stent graft master.
Graft master. So
Yeah, graft master, yes, the old one, which is very bulky disease.
To have a lower profile graft.
We didn't have it then in the cath lab. So it was a very bulky stent. So, okay, the bedside, again, ultrasound in the cath lab was fine. There was no significant pericardial infusion. I thought that the contrast staining was mostly in the myocard. She went to the ward, was very nice. And then after 1 hour, of course, she complained of chest pain and became hypotensive. She came back to the cath lab. There was, of course, pericardial effusion and tamponade. We had to do a pericardiocentesis, and we evacuated about 300 milliliter of blood. And you can see here the pictal catheter. And now what can I do? I tried to put another drug-eluting stent, maybe overlapping of 2 stents will seal the problem, but it was not enough. And then I don't know how and how, which strat I crossed the second time, but I was able to implant finally a stent graft, 2.818, and it sealed the perforation. So the patient was fine, she was stable, she was in the coronary unit, and the next day the echo was fine, so the pigtail was removed and she was discharged home. And for me, the take-home message was keep it simple, especially in older patients. Maybe it doesn't have to be perfect because they don't really tolerate long procedures and they are prone to complications. Maybe side pot would be enough for this patient. The result was okay. Be careful with extension catheters. We had some complications. Just 2 weeks ago, we had a patient with the CT of the right coronary artery. We want to do a LAD and had a dissection of the LAD, the left main, and the circ. So she had, in one moment, occlusion of all 3 arteries and was in cardiogenic shock, but we managed to save her. And don't underestimate the coronary perforation.
So my comment, when you do in this case, a probable proximal crossing, and then you have this neocarina in the middle, and then you have a complication in the side branch, the first thing that you can do now is just do another pot, okay? another pot to relocate the neocarina in the original place. Doing another pot allows you to close the vessel. You have the perforation, and then you have maybe the time to, if you do another pot, to feel the feeling on the side branch wire. If it is, some friction, maybe it was proximal crossing. If you are distal, there is some tactical, and then re-engage immediately. You deflate the balloon, the pot balloon, or you go with the double lumen catheter or micro catheter just to go distal and occlude the vessel, not to have a perforation. And then you have still time to do a distal crossing, do opening the strut. You don't need to do a kissing, just opening the strut and go with another stent. So this is another trick to, sometimes you can have difficulty when you do this problem that you do a pot to distal and then you are unable to go. There is a complication described in the paper. If you go to distal with the pot, you close, you recognize that you are in a proximal, and then you have the time. The solution is to try again to go in another distal opening and then do what you have to do in the side branch, imaging, put in another stent, and then finish with the kissing, etc., etc. Other question or comments? Thank you. So we go on the third case. Take the stent fracture and deformation in distal left main, Zheyong Narayanan. Is here or is registered? I don't know.
Good afternoon to respected chairpersons, moderators, and colleagues. The title of my presentation is Stent Fracture and Deformation in Distal Left Main. I don't have any potential conflicts of interest to declare regarding this presentation. A 70-year-old gentleman presented with a prolonged central chest pain and dyspnea at rest. He had multiple cardiovascular risk factors. He was hypertensive, diabetic, and was a current smoker. At the time of presentation, his electrocardiogram showed ST elevation in 2-3 AVF and ST depression V1 to V6. A quick bedside echo showed hypokinesis of entire inferior wall and infralateral wall, and ejection fracture estimated was 45%. So he was loaded with antiplatelets and was transferred to cath lab for angiogram and early revascularization. So a right radial access was obtained, and a diagnostic angiogram showed a short left main. Circumflux was totally occluded just beyond the ostium. It was likely to be a dominant circumflux since the right coronary artery was a small caliber system. There was a hazy critical lesion extending from distal left main into the ostium of the LAD. And the LAD appeared to be diffusal disease, and there was another area of critical narrowing just beyond the diagonal origin. So we proceeded with the intervention. The circumflux was wired, multiple rounds of thrombus aspiration, restored flow into the infarcted artery, and patient became hemodynamically stable with relief from chest pain and resolution of ECG changes. And the check angiogram showed that the circumflux was a dominant system. We then proceeded with the intravascular ultrasound evaluation. This is an intravascular ultrasound pulled back from the distal circumflux. The distal circumflux reference vessel diameter was 3 mm. There was a diffuse plaque seen extending from distal circumflux just beyond the origin of the obtuse margin, and there was an area of critical narrowing at the site of obtuse margin origin where there was a mixed plaque with some areas of superficial calcium. The MLA at that site was 2.37 mm squared, and plaque burden was 82%. The intravascular ultrasound pullback further showed that the plaque was seen extending proximally, and at the site where the circumflux was totally occluded, there was a fibroatheromatous plaque with the luminal compromise. And in the ostium, the plaque burden was 64%, and vessel diameter was 4.1 mm. This is an intravascular ultrasound pullback from the distal LAD. The distal LAD reference vessel diameter was 3.3 mm. There was a mixed plaque and with areas of high attenuation at the site where the diagonal was originating, and the plaque was seen extending proximally. And at the ostium of the LAD, the MLA was 4 mm squared with plaque burden of 75%. The vessel diameter at that site was 4.5 mm. In the distal left main, there was high attenuation plaque, especially from 5 to 9 o'clock position, and the lumen area at that site was 3.9 mm squared. And ostium, the plaque burden was 71%, and the vessel diameter at that site was 5.6 mm. So intravascular ultrasound evaluation revealed that the vessels were diffusely diseased, and the disease was extending all the way from left main ostium into the daughter branches. In the case of circumflux, it was extending beyond the obtuse marginal origin And in the case of LED, it was extending beyond the diagonal origin. The left main appeared to be short with a significant narrowing all along the left main. So the strategy was a stepwise provisional side branch sending strategy in mid-circumflex obtuse marginal bifurcation and same strategy in LED diagonal bifurcation. And since the left main was diffusely diseased with the lesions extending to LED and circumflex ostia, we planned an upfront two-stent strategy in left main bifurcation with plan to extend the stent up to left main ostia. So the circumflex and obtuse marginal wired pre-dilated the mid-circumflex lesion with a 2.5 mm balloon, stented across the obtuse marginal with a 3 into 28 mm drug-eluting stent, which was deployed at 14 atmospheres, and followed by pot with a 4 mm balloon at 14 atmospheres. Angiogram confirmed well-deployed stent. So after that, we shifted to the LED diagonal system. The diagonal was wired. Proximal LED was pre-dilated with a 2.5 mm balloon, stented across the diagonal with a 3 into 33 mm drug-eluting stent, and then pot was performed with a 4 mm balloon with good results. For distal left main, the considerations were that the bifurcation was an obtuse angled bifurcation. There was no significant mismatch between left main and taut branches. Since the left main diameter appeared to be around 5 mm, and intravascular ultrasound showed that the vessel diameter in the proximal LED and proximal circumflex was 4 mm. So the plan was to perform a double kissing clot. So we placed a 4 into 21 mm drug-eluting stent from left main into circumflex and deployed at 14 atmospheres. And when the balloon was inflated, we can see that there was a waist at the circumflex ostium. A stent boost images confirmed that stent is underexpanded at the ostium of the circumflex. A pot was performed at left main with a 5 mm balloon at 16 atmospheres, followed by post-dilatation at the ostioproximal circumflex with a 4 mm non-compliant balloon at 18 atmospheres. LED was then recrossed. Struts were pre-dilated with a 2.5 mm balloon. And kissing balloon dilatation with the 4 mm balloons were performed. And during the kissing balloon dilatation, it was noticed that the circumflex balloon was not expanding properly and there was a waist. And once the balloons were deflated, we noticed that there was a significant break in the outline of the stent which was placed from left main into circumflex. And there was transection and discontinuity of the outline. And towards the left main, distal left main, there was the stent appeared to be crowded with and collapsed, suggestive of deformation. So at this point, we can have a discussion of the problem. We tried to get an intravascular ultrasound catheter into the circumflex, but that was not negotiable.
If you have suggestion, what can be the solution in this case? Usually, in my case, I have the shock wave, so with a big vessel like this, I go directly with the shock wave I have in the shelf. The other things to remember is that if you go with a balloon, especially a big balloon, which was just for all balloon, if the balloon doesn't inflate, okay, or you have a fracture, when you remove the balloon, the wings of the balloon can catch the stent, and then you have, you increase the probability to have a longitudinal deformation of the stent toward the proximal part. So maybe it was not fractured, but you pull part of the stent and then you detach the stent from the position, the original position. So this is my interpretation of this. Other comments or suggestion about this complication? Otherwise, we can go on with the case. Yeah, if you have it depends on the connection of the stent. If you have 3 connections, when you have this so with 2 or 3 connections, you have the probability, for example, with 2 connectors is a higher probability to have this longitudinal deformation, as demonstrated with the well-known fewer connections stent. I don't nominate, but Sorry.
Yeah, sorry, I'm still a bit confused with that Ivis picture. Did he recross into the circumflex? Because to me, it almost looks as if he might have recrossed and sort of gone between struts, in and out kind of thing. Because if your stent, when he deployed the stent, if it was as tight as we can see on that Ivis picture, he would have seen a waist that's like, piss tight. So, and that's not what we're seeing. So to me, it almost looks as if he must have recrossed, gone sort of behind stent, in and out of stent struts, and he's now crushed a bit of the stent against the side.
My impression was that the waist was distal to the bifurcation, was in the proximal part, not the bifurcation. It was a paraosteal hardening plaque. Then probably removing the balloon, it was like to be.
Sometimes when you fit the inflator, you put dye and you put saline. You put a lot of dye and very minimal saline, and then you deflate.
It's not deflated, especially. Okay, I had the case. I removed completely the stent. I do the kissing balloon. Yes, I do the kissing with the 4.5 and 4.0 balloon, and then when I deflated the balloon, but I was used to pull back the balloons together, but it should not. Until the balloons are in the guiding catheter, you should not put together. So one balloon at a time in the guiding catheter, and then together. I did together, and then some friction because 4.5 and 4.0, and then I remove everything. The wire were there. And then when I removed the stent was at the tip of the two balloons. So there was no stent. I extracted the stent completely. Because with the wings of the stent, you can really, and it was a lower, the type of stent that I told you.
With the bigger balloons, you don't need to put a lot of dye because when you deflate it,
yes, and also
it makes
remember,
wings, and you can pull the stent while you are taking it
and then when I removed, I checked the balloon, the 4.5 balloon, and then when it was completely deflated, the wings were so. It was like a
glue,
flat balloon,
like glue attached to the metal of the stent.
Thierry?
I like to say that time is our friend. For inflation, at least 30 seconds inflation to have a full deployment of the stent, 30 seconds. It was demonstrated by several studies. But the same for deflation. It was time, 15, for example, for left main. I agree. Yeah, but we see every day people doing live cases, inflating 5 seconds, deflating, and removing the balloon like that. So 30 seconds at least. Second, deflation, the same. So you need to see that there is no fluid going back when you deflate the balloon. And usually it takes 15 seconds. And if you have a long balloon, it can be 20 seconds. So it's very important. So it's not a question of course, if there is more dye, you need more time. But if you have a perfect 50-50 solution, I think it's at least 15 seconds. So we need 30 seconds inflation, 15 seconds deflation before removing the balloon.
Another things I do, usually before pulling, I push the balloons when they're so big. So I push the balloon, the guiding catheter is going, I move the balloon from the position, then I pull. So this is another trick. Push first.
Just a
yeah, but in this maneuver you wait a little because you have to push and then you remove.
Just a short comment, because what we see, a very complex procedure, and suddenly we have a stent in the left main, and we don't really know why it ended there. The explanation could be what we have been discussing. It was captured by a balloon who was not totally deflated. It was retracted back to the left main, and then it was taken off by the guiding catheter from the balloon, and then it ended in a shrimped version in the proximal part. And that could be one of the explanations for that, but do we have more from the case? Do we see more? Is the case finalized, or do you have more?
Yeah, go on with the case. I don't know how. Can you go on with the case? No. There should be the continuation of that registration.
It's not totally dislodged of the left
followed by
main.
report. It was react.
The left main is okay, but you cannot engage the catheter properly to the left main, but everything's fine. Would you snare this stent out of the left main?
Proximal
Good snare.
circumflex lesion which was uncovered by stent struts, and there are also areas where there was partial fractures, which is defined by more than 1/3 of the circumference uncovered by the stent struts. And especially towards the ostium circumflex, there were absent stent struts from 3 to 6 o'clock position, and in the point of confluence, there were absent stent struts from 3 to 7 o'clock position. The mid shaft, the stent struts, stent geometry appear to be intact. So we changed the strategy. Stent struts towards the LED was opened again with a 2.5 mm balloon, placed a 4 into 15 mm drug-eluting stent from ostium of the left main into the LED, followed by pot with a 5 mm balloon at 16 atmospheres. Then after that, circumflex was reaccessed. Kissing balloon dilatation with 4 mm balloons in LED and circumflex were performed. At this point, we noticed that the circumflex balloon was expanding properly, followed by report with 5 mm balloon at 16 atmospheres. Then we placed a 4 into 12 mm drug-eluting stent at circumflex ostium in a tap fashion. After that, a kissing balloon dilatation was performed after pulling back the balloon slightly to the left main. Intravascular ultrasound pullback from distal circumflex. The stent appeared to be well expanded and opposed in distal and mid portions. In the osteoproximal circumflex, where there was a stent fracture, the lesion appears to be well covered, and in the ostium of the circumflex, the minimum stent area obtained was 10.5 mm squared. This is the intravascular ultrasound pullback from the LED. The distal and mid portions, the stent appeared to be expanded properly, and the ostium of the LED, the minimum stent area obtained was 10.7 mm squared. In the distal left main, the stent appeared to be well expanded, opposed, and the minimum stent area obtained in left main was more than 13 mm squared at distal, mid, and proximal shaft. And this is the final angiographic results. There was no residual lesion, and the there was good flow in both LED and circumflex. There are multiple predictors of the complication, which has been described to happen between 60 days to 4 years after the implant. When we place the stent in angulated branches, this can potentially alter the vessel geometry, and interactions between the torsional movements and the metal can lead to metal fatigue later and potentially lead to fracture at a later date. The first generation drug-eluting stents, especially cipher stents, are more often associated with this complication, but there are also reports that the second generation drug-eluting stents can also be associated with fractures. In a series of patients who underwent everolimus eluting stent implant, the incidence of stent fracture was described was around 2.9%. When we use overlapping stents, that can induce axial stress along the vessel wall, and these overlapped portions can serve as hinge points where the vessel can potentially fracture at a later date. When we implant stent in vessels which are affected by considerable motion during the cardiac contraction, like right coronary artery and saphenous vein graft, that can also serve as potential areas of strut fracture later. When we implant longer stents in smaller vessels, that can lead to stent strut fracture at a later date. And among the clinical predictors, patients who have chronic kidney disease and hypercalcemia and calcified lesions can also described to be associated with this complication in literature. Our patient is unique in that the stent fracture was recognized immediately after the implant, after the post-dilatation. And there were several predictors which has been associated with this complication. We placed the stent in ostial location where the recoil is maximum. There was acute angulation, there were overlapping stents, and we performed high pressure dilatation. All could have contributed to stent fracture immediately after the implant. And stent enhancement views are very useful to detect strut fractures, and intravascular imaging would help to define strut fracture and plan treatment in patients who are affected by this complication. Thank you for the patient here.
So to summarize this, there was a stent fracture. The operator finished with a planned procedure, which was decay culotte, because he put the first stent in the circ, and then he had to finish with the culotte because they also already, and then he crossed, and then he did a T, a provisional T. So it was a decay culotte plus a provisional T where there was the fracture or the modification. Yeah, was it a fracture? Practically doesn't matter, fracture or deformation. There was a gap there, and you have to finish your plan, which was decay culotte, and then cover the part that was not covered by stent.
Wait, what was the stent in the circumflex?
The type of stents?
Yeah.
What type of stents did you implant?
That was thin strut precoding stent. It was an Ultimaster stent. It was 421 mm Ultimaster stent.
Ultimaster stent. So it's thin struts and also less connections. Okay, thank you. Okay, we go on with the next presentation. From Jessica Sikik, which is a stent dislodgement, coronary perforation, cardiac tamponade, and I don't know.
Better pronunciation, thank you. So, thank you so much. I don't have just one complication in this case. I did it more together with my colleagues. So, this case started with a non-STMI, and this lady who was born 1956 had a torsade point also, and she was transferred to CCU, and after that to the cath lab. And that was her previous history. So she already had a myocardial infarction in 2007, and she was treated with BMS because at that time we don't have drug-eluting stent, and she also had a PCI of LAD with BMS, and a year later, due to extension of atherosclerotic disease, she received another stent. It was also BMS. And then we treated a complication of BMS, and that was late instant restenosis, which she had in 2014. And then again, 4 years later, she had a myocardial infarction on the RCA. It was a late instant occlusion, and we treated that with 2 drug-eluting stents. She had also hypertension, hyperlipidemia, atherosclerosis of the peripheral artery, and she was a smoker. And then she transferred to the cath lab, and this is the chapter 1. So, as you can see here, she had occluded RCA, but this ACX was the culprit lesion. And at that time, it was my younger colleague in the cath lab, and it was looked like an easy procedure. But as you remember, she already had implanted stent in the ACX, and at that time, we don't have imaging techniques. So she tried to open this ACX. She put a wire, she ballooned it, and she tried to implant this science, but what happened, she lost the wire and she lost the stent as well. So this stent was protruded a little bit in the left main with a few struts, and then she called me to help her because I'm older. So now we have a problem because we have a lost stent in ACX without a wire, and we have also a protruded stent in the left main. So I tried to put the wire through the stent, and I tried with the BMW Elite, and then I finally crossed with the Pilot. And my idea was to implant the stent in the distal part of this dislodged stent and just pull it out. And I thought that it will be a good idea, so I did it with that 1.5, but I think I showed that stent was too thin because I just passed through that stent, and I just, as you can see in this right picture, I just move out that dislodged stent a few millimeters into LAD, and it wasn't protruded with only few struts. Right now, it protruded completely over the LAD as well. So my question is, what would you do now with this situation?
So you were across the stent with the wire, you are sure? You crossed with the...
Yes.
You removed the stent.
Yes.
Yeah. Now we have a wire.
Yes.
Side, and you have more protrusion in the left main.
Yes.
You have a snare, you can snare, you go with the snare and you snare everything. This is the, the first solution, which is because it's in the left main outside the guiding catheter. And this is my first choice usually.
I tried, but it didn't work.
You try with the snare?
Yes, I tried and it didn't work.
If you try with the snare, then the last solution, because if you do other maneuver, you can have 2 wires to envelop, to go with 2 or 3 wires to try to with the snare to remove, but you have to pay attention, because if you deform the stent, then you lose the stent in the aorta. So you have to think about crushing the stent with an additional. This is the most safest way to
That's what I did. So I passed with the 2 wires through the over the upper part of the stents. I use stent boost and stent boost alive, so I was sure that I am in the right position, and I crushed the stents with the balloon. So first I use a balloon for left main and LAD, and then to ACX, and then I implanted stent in the ACX, and then I implanted stent in the LAD. I recross the wire and I perform a kissing balloon, and this was the result. Angiographically, it was good result, and I was really happy because of that result. Oh, okay, go play. But only angiographically, because I know that I didn't do a report, because I was a little bit afraid of the report.
But which technique do you use for the 2 stents? It's a T or it's
it was T-stent technique.
T-stent.
Yes. And I didn't perform a report of the left main because I was afraid of that protruded stent. And because she was stable, I planned to let her go to the CCO, and then because she also received a lot of contrast at that time, and she became not very well and not very comfortable to stay at the table. So the idea was to bring her back to the CCO and see what will happen, and after that I will do optimization. So that is chapter 2, part 1, optimization. Because I let her home, and after 3 weeks or a month, she came again to the cath lab, and this was the result of a previous procedure. So as you can see, that is not very well expanded stent in the ACX, and not very well expanded stent in the LAD as well. But this dislodged stent is completely covered with the stents, as you can, as I saw on the with the stent boost. But when I performed this OCT, this in the middle part, I saw that there is a lot of problem with the stent, because there is not very well expanded stent in the left main, and also I'm not satisfied with this picture. And also as you can see, this dislodged stent, which is not a very good stick to the wall, and there is also an empty area around it. So I took Accuforce, I took a track, I post-dilatated, and after that I post-dilatated these stents in the ACX, and then also stent in the LAD and left main, and this was the result. So the optimization, I thought that is good. With this angio, I showed no residual stenosis. And you can see also stent boost that all stents are very well expanded. And on the with OCT, I showed that this ostial part are very well without any problems with dislodged stent and any other stress stent as well. So I thought that I am finished, that I did a good job, and the patient was good. And I sent her back to the ward, and I went home. But a few hours later, they called me because she became hypotensive and in a cardiogenic shock, and she had a tamponade. So I was thinking, okay, she had a tamponade. Oh my God, that can be only due to dislodged stent in the left main, because I did that optimization, and I was so worried about it, because if it is really true that I don't know what solution will be for her, how to treat this patient. So I brought her back to the cath lab, but as you can see here, it wasn't dislodged stent. I perforated the vessel with the wire in the distal part of the vessel. As you can see, it was completely distal. So I was happy, okay, it's very distal, I can treat it very easy, maybe with a coil, but I didn't have a coil with that size at the cath lab, so I asked another cath lab, and they didn't have it as well. So I said, all right, then I will take that bulky graft master, and I will put that graft master, but like a stent. To occlude it, because I kept this perforation with the balloon, but this perforation didn't stop with the balloon. And another idea was to take fat and to occlude it. And also I called my colleague from vascular surgery, did they have some kind of glue to put it there, but they didn't. So I took that graft master, what was a disaster, because that stent which I had in ACX, which was implanted, that BMS stent, which was implanted during the first myocardial infarction, wasn't expanded very well. So I stick with that graft master, and I feel that I am losing it. So I inflate that graft master in the mid part. And as you can see there. And after that, finally, that bleeding stopped. So I said to myself, okay, stop. So it is not just a straight perforation, it is some kind of flap. And I implanted the drug-eluting stent, and everything stopped, and patient was well, and she's still well. And this was her final result. So I think that I did more than one mistake here. Some of them is not because of myself, but some of them does. So I think that we should take care about a previous stent implantation as well. We should take in focus not just the part we are treating, but all the part of the vessel. And sometimes the easier way is not always the best. We have to take in account all possibility if we have some procedure like that.
Yes, other comments. The fat is very. There is a Ibrilakis video how to prepare the fat. It's very easy. You have to use a needle to prepare the fat, and then with the microcatheter you go down and you inject the fat. It's just it's a good way if you don't have the coils.
When you do complex cases, these things occur frequently. So this is very important at the end of the procedure to check what you have done around, all around. Do not focus on the left main that you have treated nicely with a very good result, and then you forgot to see that the wire was too much distal and you make the perforation. So this is the first thing. It should be a rule in all cases, especially if you do a complex case. And the second comment is that if you should have something to close a hole in the distal vessel. So it's very important. But if you have not, you have a very simple technique. The fat is not so easy to do. Not easy to insert the fat in the microcatheter, but you can just use a balloon. So you cut the balloon in the middle, you push it distally, and you close the hole. So it's very simple. Of course, it's not something that we are talking about because people want to sell other things, but it's very useful. If you have nothing on board, cut the balloon, push it with a microcatheter or with another balloon, and it will deploy like a parachute in the distal vessel.
So, Remo, what we do is, after, as Dr. Thierry mentioned, it should be a rule to image the. We take a simple PA view. Simple PA view gives everything in distality. Circumflex distal, LAD distal, and very often, if you, especially with a junior colleague of you, they tend to be little, I'm not saying rough with the wire, but they underestimate the potential of the wire to perforate. So just take a PA view. The last shot should be the PA view. It gives you everything in distality. Yeah.
Thank you. Sorry for the pronunciation of the names. I'm not beg my. So the last presentation is from Pablo Vidal Cales. Is correct? Nailing the bifurcation.
So, good afternoon. I am Pablo Vidal Cales, Interventional Cardiology Fellow from Hospital Clinic of Barcelona. I wanted to thank the European Bifurcation Club for allowing me to present this case. And it's great to be here in Madrid, which is my city. And also to Dr. Salvatore Brugaletta, my mentor, that encouraged me to present the case and to share it with everyone here. So the case is called Nailing the Bifurcation, and I start with the case presentation. It's about a 54-year-old male, a former smoker with dyslipidemia and diabetes, with a non-ST elevation myocardial infarction in November 2021, and a coronary angiogram then with a right coronary artery with severe mid lesion that was treated with one stent, and that was okay. And then a left coronary angiogram that I want to discuss with more detail. So here there is a left main with a 20% distal lesion, and a left circumflex with a moderate 50-60% proximal lesion, and a LAD with a definitely severe 80% proximal lesion. This case was performed in another center, not in our center. That has to be done. So the lesion was treated with the placement of an angiolite drug-eluting stent in the ostial LAD, and then a pot with a 3.5 non-compliant balloon. So this is the final angiographic result. The left circumflex was left untreated, and was left untreated depending on the follow-up of the patient and symptoms, etc. So if the follow-up at first it was okay, the patient was asymptomatic for 1 month, but then he developed progressive angina that didn't improve with optical medical therapy. So non-invasive tests were performed. ACMR showed no ischemia, but the echo stress showed angina in the test with EKG changes, but without echo changes. So there was a little bit of discordance between the non-invasive tests and the symptoms of the patient. So finally, a new coronary angiogram was requested and was performed by us in this summer, in August 2022. So this is what we see in the follow-up. I'm sorry. And I wanted to, I put the images, and I want to ask what happened here and what would be your approach.
Okay. No, I was just telling, I'm feeling a little bit, I don't know, old style, but there is nobody putting two wire in a bifurcation, even if we don't want to stent it. No, it's a little bit joke, but I think it takes 30 seconds, and it's your safety line in. And the first case was the same thing. And the second thing, again, I'm feeling a little bit of vintage, but the refusing a bifurcation is not the simple way to do. Sometimes I think we have to consider if the lesion is really next to the osteum to do the bifurcation, even if the circ osteum is not diseased at the beginning. So just.
Can you go back to the positioning of the stent in the image, the first images, the positioning? Okay, this one, the first one, this one.
Yeah.
In motion.
On the left.
On the left. Okay. What you see here, you see that the stent clearly comes left. Is moving. When you see this movement, never do. You have do a balloon assisted the stent deployment. So two wires, put a balloon, then you trap the moving, because with the balloon you trap, and then you have all the time to position correctly as snaring. Otherwise you finish with the. Yeah, very low pressure.
So I want to point out that the case, the first case was from another center. So I have no.
You can never perfectly nail the osteo of the LED. There's always plaque at the distal left main in the LED, so you have to cross over. I mean, did you IVUS this before you stented, or just angiogram only?
It was from another center, so that's I can't answer. I'm sorry. So the second, this coronary angiogram was performed at our center, and well, what we did here is we put two wires in the LAD and the left circumflex. We rewired, and we use intracoronary imaging to check the position of the wire, and we perform also a functional assessment, because the patient had severe symptoms, but the non-invasive tests were a little bit confusing, so we wanted to match the severity of the lesion with the patient's symptoms. So there was a DFR in the left circumflex of 0.5, so clearly positive, and we did coronary imaging, and what we're going to see there is a protrusion of the LAD stent into the left main, and we see that this protrusion contributed to the circumflex lesion by atherosclerotic plaque protrusion into the left circumflex. Also, we checked that the wire, it was correctly, the rewiring, it was correctly performed. So this was our simple bifurcation approach. We did kissing balloon with 3 10mm non-compliant balloons, and then we put a drug-coated balloon, an essential drug-coated balloon, at 8 atmospheres during 40 seconds, and finally a pot with a 3.5 non-compliant balloon. We didn't have another balloon available, and also the left main and the LAD size was pretty similar, so we were quite comfortable during this using this balloon. So this is the intracoronary imaging post, and we're going to see at the in the region of the bifurcation with the left circumflex, that we have good apposition, good expansion, and also the struts are more open to the left circumflex. Here we're going to see it. Okay, so the intracoronary image, also the left main didn't have dissection. This is the pre and post to summarize. So with a wider area in the bifurcation place after the procedure, and the final angiographic result was this. So it was a nice result. Also with a DFR that was clearly better than before with 0.95. So in 1 month follow-up, like 1 month ago, the patient was free of angina. He was okay, feeling okay, and no further complications were reported. So to conclude, first, the provisional stent strategy requires careful, meticulous assessment and treatment of the bifurcation anatomy, especially when the nailing the ostium technique is considered. So the pitfalls of a previous bifurcation technique may be corrected by knowing the different steps, the previous images using the prior PCI, and in our case it was important because it was from a different center. And finally, the intracoronary imaging provides valuable incremental information that the angiography may underappreciate. So thank you very much for your attention. That's it.
Thank you for, I have a final comment. There is a paper by Todd, I think, in her intervention, that when you do this pot, you overspan the stent, you do the nailing in the ostial LAD or ostial left main, you don't shorten the stent, but you elongate the stent. So they suggest not, when you have to do this nailing, to avoid to go exactly to the ostium, because when you post-dilate the stent will elongate and will protrude in the left main if it's in ostial LAD, or in the aorta if it's in aorta. So this is and there is a good film also demonstrating that when you overexpand the stent with the 1 millimeter bigger balloon than the stent diameter, then you have sometimes 1 or 2 millimeter.
Yeah. Similarly, we did a bench testing just recently. So if we stent from the left main to the LAD, suppose, and we start doing a pot from the carina, and we come towards the guiding catheter, the stents keeps on elongating.
Yeah.
Whereas if we start the pot at the ostium of the left main, the stent gets fixed to the wall, and then you go distally and do the pot, the stent doesn't elongate.
Because you elongate, you
pull,
yeah.
And this happens in the LAD ostium also. So if you put a LAD ostial stent and then you start optimizing the stent from the mid LAD up to the ostium, 2-3 struts come in front of the circumflex, which were not there to begin with. And so finally the stent is malapposed and lying in front of the circumflex, and that is why, and the cells are closed, and that is why the circumflex comes back with a vengeance.
Yeah.
Whereas once we do a crossover, the cells open with the pot, so the circumflex flow is very good, so it doesn't restenoze that badly.
These are all complications of pot. You know, you have new complication because with the new technique that you use, these complications were not known before pot. So we have to learn from these cases that pot should be used correctly, and also the stent positioning maybe should modify compared with the past.
What is the diastolic free ratio is a functional ratio. Diastolic free ratio. Non-hyperemic, exactly. Non-hyperemic, yeah.
RFR, there are different names. Okay, I think that we can finish this session. It was instructive, and I hope that you enjoyed also.
So good afternoon to anybody. I mean, it's a big pleasure for me to start this session. This is a Women as One joint session with the European Bifurcation Club. It's the first, I hope, of a long series of sessions. Clearly, I'm a big believer into the importance of inclusivity and to have more women to enter into our field. Unfortunately, only 15% of women are members of EAPCI at the present time, and clearly we need to push this forward because we cannot allow ourselves and our community to not have other talented people to join us. And it's a privilege for me to chair this session together with Goran, president of European Bifurcation Club, Marie-Claude Maurice, who is co-founder with Roxana Meran of Women as One, and together with Tom Johnson, that by the way also started all of this collaboration, because just to tell you what was behind this decision was that Tom and Goran actually were joining the climbing program as clearly mentors of Women as One, and were into session, especially on coronary session, on bifurcation, and also Goran on the left main session. And they were looking to these women involved in the escalator program of Women as One, and so that clearly there is a lot of talent and potential, and need maybe to get them a little bit more involved in our field. Panelists are Javier Escaned, clearly no need for introduction, Julie Wyoming, again no need of introduction, as well as Vijay, that is also with us in the executive board of EAPCI, and should be also online Roxana Meran. I don't know if she joined. Again, founder with Marie-Claude by all the other tasks that she did in her life of Women as One, and Sarita Rao. I don't know if they are online. If not, okay, we can maybe move to the first presentation. The first presentation is going to be given by Shazia Hussain, and it is a dissection in a calcified left main, and the question is to rotablate or not.
Hi everyone. For those who don't know me, I'm Shazia. I'm one of the interventionists at the University Hospital of Leicester at Glenfield Hospital. So I'm sorry that I gave away the title already, so I'm retracting a little bit because I don't want to give away too much, and calling this Double Trouble Calcium and Dissection. I will go through this quite quickly because I think there are lots of different ways that this could be tackled. I've chosen only one, and so I'll keep the clinical scenario and images brief, and then leave it over to you to discuss what you would do in this situation. So this is a 71-year-old who presented to the Rapid Access Chest Pain Clinic with chronic stable angina. He's known to have stage 4 prostate cancer, a previous non-STEMI with PCI to the OM about 8 years ago. And whilst he was awaiting for his outpatient angiogram, he attended with crescendo angina. Okay, so these are the diagnostic images. So he was troponin negative, but he had ongoing unstable symptoms. So you can see there's a codominant system. I'll play the left system there as well. And disease there in the distal large PDA. And then I don't know if you can appreciate it, but there's calcification at the distal left main stem, disease mild to moderate at the ostium of the circumflex, and further severe disease at the large AV circumflex going onto a large posterolateral branch. And these are just further images. And there on the spider view there you can see the calcium there in the proximal LAD extending into the left main. So management plan then was to take him off the table and discuss the strategy. So decide whether he should have surgery, as he's got 3-vessel calcific disease with a left main lesion, or to have PCI. And also I wanted more information about the prognosis from his prostate carcinoma, which was felt to be resistant to therapy. So he had a prognosis of 12 to 18 months. It was discussed with surgeons, and on the basis of that, listed him for PCI with imaging and calcium modification. And my plan there, because I thought the circumflex was involved as well, was to do an upfront two-stent strategy with rotablation and probably a culotte. Okay, so all straightforward up till then. And then I start the case. Well, I don't start the case. I go to scrub whilst my senior registrar is starting the case. He's very independent. I'm happy for him to start. His radial approach, 7 French guide, and that's the first image we get. So any thoughts on what we should do now? Patient has chest pain, no ST elevation at this stage, but is hemodynamically stable. Okay, any thoughts? Apart from shout for help? I mean, that was my thought as well. So fortunately, we have a good team. So a colleague came and we discussed options. But I thought really there's not much in the way of imaging there. So left the guide where it was. I scrubbed in and took the next picture, which gives some more information. So in the interest of time, I will tell you what there is. I did actually image it all. So my first plan was to be able to stabilize all the vessels. So I wired, relatively easily, I have to say, the LAD, I wired the circumflex, and I wired, I wired the OM, and I wired the AV circumflex. And what my thought process at this stage was I wanted to see how far, I mean, it's obviously dissected. We've got an ostial left main dissection in a patient who's got a lump of calcium at the distal end. My thought at this stage was I need to know how far this dissection extends and then plan my management strategy according to that. So I imaged it all, and fortunately the rock at the ostium of the LAD protected the LAD. So the dissection extended from, I don't know if the images, haven't got them there yet. So the dissection essentially extended from the left main into the OM. So the AV circumflex is okay. The dissection's not extended down there, and the LAD has not extended. So, the dissection's not extended into the LAD. So, any other thoughts on strategy here? So, I've got a lump of calcium in the LAD, which my intention was to rotablate. What do I do first? Do I secure the left main dissection? Where do I stent to? These were all thoughts that were coming through. And also needed to think about his long-term prognosis, 12 to 18 months. I didn't call the surgeons. This is an acute issue. I needed to deal with it there and then. In terms of PCI strategy, I'm not saying that I had the right strategy. This can be done in lots of different ways. You could stent left main to LAD, left main to circumflex. At what stage do you start modifying the calcium when the left main's dissected? And how do you modify it? Do you rotablate it? Do you do IVL? I mean, anybody on the panel would like to suggest what they would do?
There to also support the patient, because with the dissection like that of the left main, clearly it was hemodynamically stable at the time, but
to be honest,
go in ventricular fibrillation.
We don't have impeller at our center, and he tolerated it well whilst there was no flow. And then after that, there was always flow in the coronary arteries. So whilst there was flow in the coronary arteries and there was a good blood pressure, I thought it best to go on and deal with the intervention.
If I can share something from my experience in several occasions that I've seen dissection of the left main. The first lesson I learned is stop injecting contrast, blindly wire, and then use IVUS first to document the position of the wire.
Yeah.
So my question for you is whether wire in the circ was in the true or in the false lumen?
Yeah. So I don't have the IVUS images, but that's exactly what I did. So I took the first initial picture to see what was happening. After that, I wired and then IVUSed all 3 limbs to make sure that my wires were in the right place, and they were, and not within the dissection. I have got some images. And then after that, once I'd secured everything, then I started thinking about my interventional strategy.
Yeah. Javier wanted to ask something.
No, I think that you already mentioned it in a way. I think that this is a very good scenario to be trained in ultra-low contrast PCI. This is the situation where, typically when you speak about ultra-low contrast PCI, people think in chronic kidney disease. And we try to insist that there are many situations, clinical scenarios where this is of paramount importance, and certainly this is one of them. Iatrogenic or therapeutic dissections, like in ADR, for example, is one of the situations where it really helps you a lot. So I think that obviously from that perspective, what I will do is try not to extend hydraulically the dissection with injections, try to secure branches with wires, and then I think that you will have an impression that you have reached some good position of the wires, dilate, and then use IVUS. I think that that's what I will do.
So what are you going to dilate and IVUS first? What's the plan? And dilate first.
I think I will dilate. Obviously you know the anatomy much better because you have prepared the case before going into the room. But I think that if I get it towards if the intention first was to go with the stent towards your LAD, I don't remember what it was, I will dilate in the direction of the LAD. But I will secure that there is a flow. And I think that soon you will have evidence that things are going properly. Just look into the EKG.
So I'm just putting the IVUS up on the LAD. So I've established that the dissection has extended into and been stopped by the stent in the OM. So it's gone straight down the path of least resistance, which is down the OM to the stent and stopped there. This is the LAD into the left main stem. You can see towards 12 to 3 o'clock. That's the dissection coming in from the circumflex, and this is the left main dissection. Sorry, I can't play it. Can you play that again, please? I can't play that. Sorry, the one before this one, please. Thank you. So as you can see, there's a spiral dissection of the left main calcific disease in the LAD, and what looks like a fibrocalcific disease there towards 10 till 12, and a nodule of calcium, which is what we're seeing on the angiogram, and there that dissections coming through from the circumflex into the left main. You can see a huge dissection there. So any other thoughts on what anybody would stent first, how they would modify?
No, I was just going to make a point. I've seen this case you present elsewhere, so I know the story. But general comments, I see a lot of our young colleagues in the room. Just to emphasize, this does happen. It has happened to me when either our junior colleagues are operating, or it's happened to me myself with the guide wire. And the important thing is that is not to panic. And the surgeons will not. They'll come and observe from the observing room to see what you're doing. So it's up to us to fix the complication when it happens. And you have done exactly the same thing. It's just to take over, get your guide and get your wire in the right place. As long as you've got your wire in the right place, you're fine. And the different aspect to your case is the calcium. Obviously, if you have your wire and you want to seal your dissection, but then with calcifications, adds to the extra complexity, which I think you've handled very well. So that's a point. And again, the impeller, we don't have it other than clinical trials. We don't use balloon pump anymore. So as long as you secure TIMI3 flow and the patient's ECGs are fine and he is not hemodynamically compromised, you go ahead and fix the artery and get the flow going. That would be the first thing we prioritize doing. But there are instances where you do have to provide support when you haven't quite achieved a TIMI-3 flow and this persistence of hypotension, etc.
No, I'm saying that because exactly last week it happened in my lab to my fellow. And by the way, this was an INOCA case that was interesting. We finished the case. So I was looking to the console and I turned and I saw a cloud. And actually it was complete dissection from the ostium, but the patient went in cardiac arrest. So it was an ECMO and impella, ECPella, and the patient now is fine, luckily. But clearly it can happen even into a diagnostic, pure diagnostic. Yeah. So you have to be prepared. Your point is pay attention. If it's radial, get an access because they can go also in cardiac arrest and ventricular fibrillation.
Okay, I think we need to move. Just a word, you just say that in the option you consider rotablator, let's say left main dissection, you need to keep the Y. So I would forget rotablator immediately. Yeah.
Would you forget it? So these were the thoughts I had. So I didn't want to aggressively balloon the LAD because you've got a dissection in the left main. What I don't want to do is propagate that dissection down the LAD. I've already seen that it's calcific. I'm not going to get an IVL down there. I can't do a bifurcation strategy without modifying that calcium first. So the issues are, do I calcium modify or do I secure my left main? Okay, so my strategy was to secure the dissection downstream. You could argue it's secured already, but what I didn't want to do was modify the calcium, potentially disrupt the left main dissection and make the flow down the circumflex worse. So I went on to secure the dissection in the circumflex first with a view to rotablating the LAD. And obviously I had to be very careful here with positioning. What I didn't want to do was put a stent back into the left main where I would then rotablate. So I will take everybody's criticism that it will be a suboptimal result. My ostium of the circumflex is not covered. So I'd taken measurements already with the IVUS and deployed a 3.5 by 28 synergy, which I'd post-dilated with a 3.5, non-compliant and potted proximally with a 4.0. And that's my result there into the OM. So the distal dissection is secure. I'm hopefully not in the left main. I think I checked that with IVUS. So there's no stent struts in the left main. And then I've been told that rotablation in dissections is contraindicated. Okay, but in this case I felt I had no choice. I thought it was the best way of modifying. And there is this principle of differential cutting, so whether I could avoid the dissection and do just the calcium. So I exchanged my LAD wire for a floppy wire and proceeded to rotablation with a 1.5 and a 2.0 burr. Okay, and then the question is the sizing of the left main stent. My sizes there are a bit inaccurate, but they were done in rather a hurry. I didn't think I would be presenting this at the time, obviously. So what size stent would people use? We've got a 3.5 distally, and then how do you size your left main stent when all you've got is a spiral dissection? I decided to stick with the middle and go with a 3.5 Megatron stent, which has then got a post-dilatation limit up to 5.86, and that would be appropriate. So I deployed that from the left main stem into the LAD. And bearing in mind the whole LAD is calcified, so I'm going to deal with the issue and not worry about the distal disease. I then optimized with a 4.0 NC in the proximal LAD and a 5.0 NC. I didn't overdo it in the left main because I had the options to IVUS. So those are the images that I've got, and I've got some final angiographic images. You can see the AV circumflex is pinched there. There is some disease at the ostium of the circumflex, and as I've said, it's a suboptimal result. But in terms of IVUS, if I run that, that's from the LAD. The image on the right, which is again poorly delineated, but showed an MSA at the tightest part in the LAD, which is around the area of the nodule. So you can see it's well opposed. The area of eccentricity will come here now, which is the nodule. So it's been modified, and that MSA is 7.72. And then now we're coming into the left main there, which you can see is a good-sized stent there in the left main. So that's the case. And then the questions are, would anybody do anything more, any further
there was
optimization?
not a dissection distal to the LAD stent, because from the angio it appeared to have a dissection distally to the LAD stent.
There was just IVUSing it all the way down. There was
not?
just calcium all the way down. So no dissection there.
Shazia, the music's playing because we're running
Okay.
very late. But
Okay.
it's a fantastic save of a truly hideous complication. But what I'd like to say, because we shared the fact that we were on the Women as One climb program together for 6 months, is this is exactly what Women as One was all about, which is bringing people to the podium who have every right to be here to stand up and share cases which are of the highest quality. And what was most humbling about my 6 months on the climb program were the stories that came from the women that I shared that platform with. And I was the only male, with Alison Dupont in Florida sharing it with me, but you, another colleague from the UK, 2 from Italy, 2 from Peru, 1 from Venezuela, magnificently 3 from Fazila Malik in Bangladesh, 1 from Canada. And the bit that struck me was your first comment was to call a colleague. And what was most striking was that most people are not in the place where they can call a colleague or feel necessarily they can gain the support of a colleague. Now, whether that's gender related or whether it's just healthcare service provider related, I'm not sure. But that's probably the most striking message that you deliver here, which is to rely upon your colleagues to help in these most stressful circumstances.
Absolutely, and to believe in yourself, actually, that you can deal with it and you can have a good outcome as long as you take it step by step.
So thank you.
Yeah, that was a fantastic case. Very well done, Shazia.
Thank
Brilliant
you.
work.
Sorry, and just to update, I've kept him on dual antiplatelet therapy. I didn't optimize, and his prognosis was 18 months. It's been a year now, and he's had no further cardiac events. Thank you very much.
Thanks a lot. Thanks a lot. Can I ask now Kalevani Mahedevan to... it's a video presentation, I imagine? Yeah, it's virtual, sorry. High-risk left main PCI in anterior STEMI hanging between a rock and a hard place.
Good afternoon, everyone. It's a huge privilege to be able to present a case from our centre, Portsmouth Hospitals, today. Thank you so much to EBC and to Women as One for this opportunity. And the case is titled High-Risk Left Main PCI in Anterior STEMI Hanging Between a Rock and a Hard Place. I have no conflicts. So the clinical presentation is of an 85-year-old male that came out of hours with severe cardiac chest pain. He was functionally independent and cognitively excellent to baseline, with a background history of hypertension, hypercholesterolemia, and peripheral arterial disease. ECG showed anterolateral ST elevation, and an emergent echo in the lab showed severe LV with an EF of 25 to 30% and some mild aortic stenosis. We did an angiogram and measured an LV EDP, which was 23 millimeters of mercury. His SATs were 90% on 4 liters of oxygen, and he had a blood pressure of 90/60 with intermittent metaraminal boluses. ABG revealed a lactate of 1.6. So this is his diagnostic images. As you can see on the left system, there's heavily calcified distal left main and LAD with an LAD occlusion, the culprit, of course, of his STEMI. There's moderate disease in the ostium of the circumflex and further moderate disease at the bifurcation of the circumflex to the obtuse marginal branch. Both branches are quite big. And on the right system, there's proximal disease and a further lesion in the mid-vessel that looks hazy and probably calcified. That's a little bit hard to appreciate on these images. So I was unable to deliver a 2 mm semi-compliant balloon, probably due to calcium in the distal left main and the ostium of the LAD, and in the end used a 6 French guide extension with a 1.1 mm across CTO balloon, which eventually delivered, and I took that up to 18 atmospheres. This changed the case actually, because we were then able to get reperfusion, and I was able to sequentially balloon to make space to deliver an IVUS catheter, which gave me lots more information. The IVUS itself was to delineate the left main bifurcation anatomy, to look at the circumflex ostium, and to define potential side branch jeopardy, and to assess landing zones and calcium modification strategy in the left main and LAD. So these are the images post-reperfusion. As you can see, again, a lot of calcium, and TIMI sort of too flowed to the distal LAD at this point. It's a 2.0 semi-compliant balloon up on the top left, and then a 3.0 non-compliant balloon, and there was some wasting in the ostium of the LAD here. And the image on the lower left is just IVUS catheter into the circumflex. So the across CTO balloon that changed the course of the procedure is actually a small 1.1 mm balloon with a 4 mm tapered tip, and is good to enter heavily calcified lesions or proximal caps in CTOs. It has a lubricious shaft and is made of burst and puncture resistant material. So actually you can take it to quite high atmospheric pressures in calcified lesions, and it's pretty good and doesn't burst. We calculated some scores, and the protected PCI score was 5 based on a high syntax score, a systolic blood pressure less than 100, STEMI presentation, left main revasc, and an LV EDP of 23. The lactate being normal meant that his SCAI shock risk stage was B, so he wasn't in shock despite needing inotropes, because there was no evidence of hypoperfusion as such, but he was pre-shock and therefore at risk. At this point, I called down our intensive care registrar to come and support with an inotrope infusion and assess the circumflex ostium with IVUS. This showed an osteal MLA of 7.9, a reference lumen area of 14.7, and an overall area stenosis of 45 to 50%, so well below the 70% in the definition 2 scoring system. The lesion length was less than 10 millimeters. So again, all of these parameters suggesting the best strategy to be a provisional left main, with a plan to kiss at the end to open struts across the circumflex ostium. And if the vessel was significantly dissected or I lost it, the plan was to then salvage with a culotte, but that would be the very last resort. The IVUS and the LAD showed significant amounts of calcium as expected. In the bottom right, you can see that there's sort of concentric calcium with some dropouts, suggesting that there's probably some deep wall calcium. You see superficial calcium in the top right with reverberation artifact. In the bottom left, there's evidence of nodular calcium in the distal left main and the ostium of the LAD. And in the midshaft of the LAD, the left main, again, there was concentric calcium. This was after a 3.0 non-compliant balloon, so I felt that I had to do more lesion preparation. And this is where having some ICU support was very helpful. So an IV metaraminol infusion was commenced, and 40 milligrams of furosemide was given as a bolus, which actually improved his oxygenation and offloaded a little bit. I was then able to take a 325 Wolverine, a 3.5 non-compliant balloon to the LAD, a 4.0 score flex to the left main and ostium of the LAD, and a 4.0 shockwave to the left main and proximal LAD. We delivered all the pulses. The final 20 pulses were delivered in the left main with the help of a little bit of intracoronary phenylephrine, which you see here on the image on the right. And he tolerated it quite well, actually. And repeat IVUS after full lesion preparation demonstrated now really good calcium fracture throughout, with luminal gain seen in the LAD and the left main, and there was dissection in the left main as well. So I was happy now to go ahead and deploy a stent. I put a 3.5/48 Zion Sierra that had been strategized on upfront IVUS in terms of stent length and platform, and the stent looked well up. I then took a 4-5 non-compliant balloon to pot in the left main and tried to recross into the circumflex, but struggled. I think because of support, angulation, and calcium, I was able to get it into the circumflex after potting with a 5-0 non-compliant balloon, but struggled to advance it into the vessel itself and was afraid of dissecting the vessel and decompensating him. I attempted with a Scion Blue, a turn track, and a pilot 50 and then failed, so I stopped. Decided to go ahead and optimize the LAD and left main, which I did with a 4-0 non-compliant balloon to 20 atmospheres in the LAD and a final 5-0 non-compliant balloon, including flaring of the aorto-osteal junction in the left main. And this was the final result in the LAD, you'll see here, with TIMI 3 flow and good stent expansion angiographically. The final result in the circumflex, not so satisfactory. You can see that it's desperately hanging on for life, but with TIMI 3 flow. And the IVUS, final IVUS in the LAD and left main showed good expansion in apposition. There was some eccentricity to stent expansion in the ostium of the LAD that you see in the top right-hand panel, so the green outlined box. But the minimal stent expansion index was 0.84, so well above the 0.8 that predicted stent thrombosis in the Prestige registry. And if you look at the top left-hand panel in yellow, there was reasonably good flaring into the aorta with no evidence of longitudinal stent deformation. So that's just to show the final IVUS result. I was pretty happy with this. It was above the 11 millimeters squared in Excel that predicted the lowest Mason TLR rate. It was below the 13.4 millimeters squared in Noble that gave a 5-year TLR of 0%, but I think given the nature of the calcium, there was always going to be some eccentricity to stent expansion in the distal left main and ostium of the LAD, which couldn't be helped. And the final IVUS run successfully excluded any LSD, which we know has a prevalence of 6.5% from the XL IVUS sub-study in the left main. There are devices that help with this, the Flash Ostial being the primary device, and this is used frequently in the States as it's FDA approved, but we don't have it in Europe because it's not CE marked. Clinically, he did very well. The inotropes were weaned at the end of the procedure, and he had a systolic blood pressure of over 100. At 72 hours, we had a pragmatic discussion with the family about staged relook at the circumflex ostium, plus or minus a KISS to correct the ostium and addressing the severe right coronary disease. But he was mobilizing well and completely pain-free, and the patient himself opted for medical therapy, which I think is very reasonable. He had an echo at 72 hours that showed an EF of 35 to 40% and was discharged at 6 days on optimal heart failure therapy and dual antiplatelet therapy. I phoned him up 9 months post his event, which was a couple of months ago, and he had an unlimited exercise capacity with no angina and was actually mixing concrete to lay himself a new driveway on the day that I called him. So doing very well. So the learning points here for me were multiple. Specialized use of CTO balloons can be helpful in non-CTO procedures. The across CTO balloon really did change the case for me in this situation. IVUS is absolutely paramount to guide your left main delineation of anatomy, to look at the circumflex ostium in this case, and to guide calcium modification strategies. Use of cross-specialty collaborative input to optimize the patient alongside the procedure allowed safe and effective lithotripsy utilization, in this case to modify calcium and to get the best possible stent result. And personal growth for me, this was a case of learning to walk away. It's difficult once you're invested to see a circumflex hanging like that, especially in such a big vessel, but you sometimes have to think that actually walking away is the safer thing to do, and it's much more important to put safety above the fear of a suboptimal result or your own self-pride in chasing a perfect result, because you can always come back once the patient's stabilized. So thank you very much for listening.
So that was a great case. First of all, many congrats also to share this case, because sometimes it's also sharing these cases and all the points that actually you stressed out, and sometimes you have to stop. I agree. Any questions? So there was a question from the audience.
Hi, it's Chris Emikides from South Africa. I think it was an excellent case, but my one concern in the way I look at sort of bifurcations, especially left main circumflex, is that provisionally is fine and you can leave the circumflex alone as long as you know that you can get back in there in case of an emergency. My concern with this case, I agree, pull out, but I would have definitely gone back either soon after that, because if you cannot cross a circumflex when there's already flow down and you know where you're going, if that patient comes with an osteal circocclusion, it's going to be close to impossible for you to then recross in an acute case. So I think it was an excellent case, but my concern is if it had to block, and thank God it didn't, you wouldn't have been able to get back there.
Can you hear me?
Yes.
Yeah,
yes, please go ahead.
Yeah, that's a fantastic point, and those were exactly my thoughts in the lab at the time and afterwards, actually. So I'm fully with you on that. We know that these stents in the left main that go across the ostia of the other branch endothelialize, and it can be difficult to get back in, and that's why a lot of us will kiss to ensure that we open up the struts. I had a little MDT actually with a couple of my colleagues, and given the patient's age and his wishes to not go back to the lab because he felt well, we agreed that it was a reasonable thing to do to medically manage him, and he's aware of the risks of not completing the revascularization procedure. But I fully agree with your point, and I think if he was sort of a younger, physically sort of more active, less comorbid patient who had said, yes, I do want to go back in, we'd have absolutely gone in, and my plan would have been to go in with 7 French access, 7 French guide, and take a dual lumen catheter and do it as an inpatient, as a staged procedure, and wire the circumflex and finish the job. So yeah, really good point, and I agree with everything that you've said. It was more on the basis of his age and his own wishes that we didn't proceed.
Yeah, I mean, I would have done exactly what you have done, Vani. It's interesting that these sort of patients present at 2 o'clock in the morning, and that's the time when you're battling calcium and everything, and particularly this is ST elevation myocardial infarction. So your primary strategy goal is to restore TIMI3 flow. Once you've achieved that, STs are coming down, patient is pain-free, and he's 88 years old, and you don't really have to be. It's a judgment call, and particularly it's 25% ejection fraction. You don't want to be too heroic in giving too much, and the patient will go into heart failure. So it's evaluating patients and doing the right thing, and I think you've done an amazing job with that case.
There is another question, and then maybe we have to move.
Yes, I'm Lucio Padilla from Argentina. Very nice case. Some consideration in that type of patient, an acute. Perhaps I will trade, first of all, the hemodynamic support, and perhaps to put an intraortic balloon pump in this case, that the patient was with a shock or not. Question for an answer. And then 7 French approach, perhaps in a radial approach, will be my first approach. Because
again, it is a shock B.
Doing a shock wave in a left main with a 3-vessel disease in a patient of 88 and shock is, you have to be
courageous. She was.
Yes, but perhaps we like to do that, but that's why I will try to go from the beginning with support, hemodynamic support, or trying to have the pressure more high when I put the IVL, no, in this type of, because the patient have right circ and left main and total LED with 25% of ejection fraction from the beginning, no?
Yeah, no, I think the age made the difference. 88, honestly, in Impella, I would not put in. Intraortic balloon pump give 0.5 liter minutus, and by the way, the trials were negative, but you can. I mean, clearly, B beginning means that it can go to C anytime. So,
yeah,
so very short question about the dual antiplatelet therapy. Is very advanced in age, but You listened the comment about the risk to have a back with this circ, and it was already an ACS in presenting. Are you going to change a little bit your plan now? You are prolonging the dual antiplatelet therapy or not?
Yeah, so to answer all of those things, because they're all fantastic points. In terms of support, we don't have impeller, and again, IABP, he had significant peripheral vascular disease, so I didn't think the cardiac output that would be offered in excess with the IABP was going to be worth it for femoral puncture. I gave some phenylephrine when we shockwaved in the left main. I've done a couple of these in patients with poorer ejection fractions, and I usually always put a non-compliant balloon up first for about 10 seconds to look at their hemodynamic response before I even open the shockwave balloon, because the one thing you don't want to do is open a very expensive balloon and then not be able to use it or deliver it. So trialing a non-compliant balloon up for 10 seconds in his left main, he did drop his blood pressure by about 30-40 millimeters of mercury. So we did give phenylephrine for the part of the left main shockwave, which kept his systolic blood pressure over 120 with the metaraminol infusion going. And so he never actually decompensated with that, and he tolerated it very well. And in terms of dual antiplatelet therapy, he's now 11 months post-procedure. He has a good hemoglobin, and he's tolerated aspirin and clopidogrel very well. So I have planned to keep him on clopidogrel for a little bit longer because he's doing extremely well on it with no issues, but with regular review with the GP with regards to ensuring that he's not having bleeding issues and he's not anemic. So I have extended his DAPT in view of the jailed circumflex and the left main PCI, but only because he's tolerating it very well. Excellent. Thank you very much. Congratulations again. So we move forward. Coronary bifurcation lesion in STEMI. Davor Kalulic.
Hello, everybody. Thank you very much for the opportunity to present this case that is entitled When the Worst Gets Even Worse. So our patient is a 74-year-old female patient that presented with ST elevation myocardial infarction of anteroseptal region. She had chest pain 3 hours prior to the hospital admittance. So her pre-hospital therapy included aspirin 300 milligrams. She received ticagrelor of 180 milligrams, so loading dose, and unfractured heparin 5,000 international units. Her past history included diabetes, hyperlipidemia, and arterial hypertension. So immediately urgent coronary angio was performed that showed that she had thrombotic lesion in ostial LAD, so left main Medina classification 010. So coronary guide wires were placed into LAD and the circ, and semi-compliant balloon catheter 2.5 times 15 millimeters at nominal pressure, this particular one at 6 atmospheres, was used for pre-dilatation. Subsequent implantation of drug-eluting stent from left main to LAD, so 3.5 times 24 millimeters, was used at nominal pressure with jailed wire in the circ. However, there was a residual dog bone effect, as you can see it here in this angio. So due to the residual dog bone effect, a post-dilatation was performed of LAD ostium with non-compliant balloon catheter 3.5 times 15 millimeters at 20 atmospheres. Afterwards, POT was done with non-compliant balloon catheter of 4.5 times 12 millimeters at 14 atmospheres. And here you can see a clear stent that we had quite a good result. The circ was rewired through the distal stent strut, so the wire was repositioned from the LAD, and the other wire was placed in the LAD as a preparation for KBI. However, the used non-compliant balloon, the one that we used for the post-dilatation, was unable to cross in the circ. So we used the new balloon catheter. However, this one was also unable to cross, and it was really hard to push it even towards the left main. So we thought there must be some kind of other problem, and we thought maybe the wires have entangled, and then that was the case. As you can see it here in the guiding catheter at the height of the aortic arch, the wires really have entangled. At this point, the patient started to deteriorate. The pressure curve flattened, the ST elevation reoccurred, and the patient started complaining of chest pain and difficulty breathing, and she went into cardiogenic shock. So one angio before, the one where I showed you that the wires have entangled, showed that there was insufficient contrast delivery. That was our opinion, and we made a suspicion that there is a guiding catheter thrombosis. So guiding catheter and both wires, everything was removed, and the guiding catheter was flushed with the saline, but however, there was no thrombus visible. So patient is doing very unwell, and we inserted the guiding catheter again. As you can see, there is a left main stent thrombosis. So the spiral started here. So there were multiple attempts to restore the flow. There were multiple dilatations. There was even thromboaspiration, repeated administration of unfractured heparin that she received 100 units per kilogram at the start of the procedure. She received even more. She received glycoprotein 2B3A bolus injection and continuous infusion. She was started with the inoconstrictors and for the hemodynamic support. And even CPR was performed, and part of the intervention was done under CPR. However, no matter what was done, recurrent stent thrombosis at various sites within the left main kept occurring. And it was mostly at the area of the ostium of the circ. The patient was placed on ECMO support, but unfortunately the patient died. So I wrote a few discussion points here. This slide brings a lot of hypothetical questions that, in my opinion, must be discussed every time there is such series of unfortunate events as it was in this scenario where we had the worst possible outcome. Did the patient was the anticoagulation inadequate? We didn't measure ACT. Maybe the patient had heparin resistance. Dr. Spies from Virginia reported that up to 22% of patients that undergo cardiac surgery with cardiopulmonary bypass have heparin resistancy, and they need up to 35,000 of international units in order to achieve desired ACT. Did we need FKI at all? Dr. Hakichi had a great presentation earlier today when this was discussed. We had active and multiple instrumentation of the left main during PCI. Maybe there really was the thrombus, but we didn't detect it when we flushed everything. We didn't have imaging at this point. Our IVOS had some technical difficulties. It was sent to distributor for a LiDAR swap. Was it the stent fracture? Maybe. Deformation also possible. Malapposition and under-expansion possible, but I don't think so. And did we underestimate the severity of calcification? In my opinion, the calcification was probably underestimated. Albert Einstein once said that failure and deprivation are the best educators. This is why I decided to present this case in the room full of experienced operators that can give their advice and opinions to someone who is at the start of their career as interventional cardiologist. Thank you very much.
Okay, any questions?
I'll make a comment if that's okay to start with. Again, thank you so much, Vojko, for bringing this case very it's not easy to come and present such a case such as this one. I think looking at your case, I have encountered cases where the thrombus formation and it does happen, and looking at your case, it's mostly related to anticoagulation. I think stent fracture, malapposition, it's too soon to develop thrombus at the time. And the question is, I mean, obviously you didn't check your ACT, and also what was the antiplatelet strategy? Did the patient receive ticagrelor or?
Yes, she received prior to the hospital admittance.
No, I think the take-home message, very nice case, doctor. The take-home message of this case is the plaque preparation. We have a 75 or 78 years old, diabetes, calcify, thrombus too, yes, but you pretty late with 2.5 balloon in approximately AD. Always after that, if you put a stent, and if you have a calcified plaque, you are not going to expand that stent. So this is a mechanical thrombosis secondary. I think that if you don't have, imagine what I did is to do perhaps stent boost to see the calcium and go with a non-compliant balloon 3.0, 3.5 and to do a better plaque preparation. So this for me is the take-home message of this case. For me, the stent thrombosis is secondary.
Okay, so first you are so brave to show this nice complication we learn from you and from others and sharing experiences. So usually when you get a 3.5 stent or a 3 stent and you post-dilate it to a 4 or a 4.5, because usually we do this every day in the cath lab, and you get an injection, there's a slow flow in the artery. You recognize this or no? Usually, if the stent is expanded so much, the next injection you get a slow flow in the artery. So sometimes they say this is some form of a minimal intramural hematoma that spreads distally, and then this hematoma gets bigger, so it obstructs the stents distally, and then you inject, you get the thrombosed stent because there is no flow distal. So this is one thing. The second is the thrombus on the wall of the vessel. It's like a mud, and you keep expanding. So this mud like falls from the stent struts inside the stent, in addition to the calcium, the debris, and as the doctor said, also with the atherosclerosis and diabetes. So you get all of this, like you get a no reflow after performing a rotablation.
Short.
But I can tell you, sure enough, your wires were not tangled because devices were going in and out, and definitely there was no problem with anticoagulation. It's mechanical within the stent.
Yeah.
Okay.
So please, the next short answer.
Could the bailout thrombus aspiration in the beginning of the procedure change the scenario of this patient? If you did thrombus aspiration, because
maybe then I would know that the thrombus isn't the problem, but the calcium. That I think that was the main problem.
It looks
Another
like a
comment short, please.
So, it looks like angiographic projection looks like a calcium nodule with a thrombus on the top. That's the SCS producing lesion. That's why the stent is underexpanded at the first go, and she was having difficulty passing the hardwares. And with maximum dilatation also, this is an underexpanded stent. There is a nidus for thrombus formation, and finally the patient.
This is an interventional meeting, and we have the bias to see everything from the mechanical perspective. But this is an STEMI patient with oral drugs just given 30 minutes before. This patient has not antiplatelet coverage, nothing at all. It's under zero inhibition of platelets. These huge stents only develop such a huge thrombosis if they are not with proper antiplatelet therapy. Then we have now tools like pharmacological tools like cangrelor to provide this coverage. In fact, I think that patients with STEMI and primary PCI that is complex should have these drugs, maybe cangrelor, maybe tirofiban. But this amount of thrombus, huge amount of thrombus, is not a mechanical thing. You have a residual lumen, is maybe 3 in diameter, maybe the lumen is in the area is 7 or 8. This is not a mechanical thing. It's just pharmacological problem. But the bias is because we are talking every day about calcium calcification, sub-expansion, malapposition. But this is an STEMI, and forget this, the drugs they are given 30 minutes before are not acting. patient is not under any inhibition.
I think there's probably consensus in the room that pharmacology plays an important role. What we see beautifully here is that a room of interventionists, you're never short of opinion. And the other beautiful thing to reflect on is that everyone in this room thinks they're right. But just ponder on that. But we haven't heard, most importantly, we haven't heard the response from Vojko, which was about the ACT. So you were unable to measure the ACT, but
No,
they
we
had
didn't,
aspirin and ticagrelor.
No, we didn't measure it right away.
So how have you as a lab team developed from this case in terms of are there now things that you are doing within the cath lab to prevent this happening again?
Yes, definitely. And we always, for example, when what the colleague said that he thought that we should have used the larger balloon. I agree with you, but because then we could have seen that the balloon isn't expanding well because the 2.5 did expand. But we thought, okay, it is a high thrombotic burden. We don't want to embolize a lot of thrombus into the peripheral part of the artery. But I think that was the biggest problem. So those are two things that we learned from.
Before animating tumour any further, how about the pharmacology? So do you now have available the ability to measure ACT regularly in your lab?
We do.
Okay, fine.
Theoretically, when a thrombosis complication is occurring, especially in the setting of ST elevation MI, you should measure ACT. Because
Hi.
Okay.
This is tentative ref memory. John Douglas taught me a long time ago that if you have a large thrombus of the ostium of the LAD, just put a 20cc syringe and negatively pull pressure, that thrombus is going to come back. Any other tool, like an aspiration device and all, is likely to throw that stuff down the circumflex. So almost never balloon, even gently, because that thrombus can move into the circumflex. And I've had that. The patient's gone down very rapidly. But if you put a negative syringe and suck on it, the clot is likely to come back with that clot.
Yeah. Another
last question.
So
then we have to
just
generate credible number of comments.
Sorry,
Next time I will apply with 2 cases, yeah.
Sorry, just a quick question. When you said you couldn't deliver the balloon into the circumflex, could you get it up to the ostium of the circumflex?
The first one, the used one, you're asking about the balloon?
Or the second one, yes.
The second one did, but it was very difficult to push it even up to that point.
Yeah.
So that is why we thought the wires had.
Yeah, so if you did have wire, if you were thinking of wire wrap, I always would keep it there and pull the wire that is easiest to cross. So pull the one back, see whether there's wrap. You can actually see it actually coming and go back down the easier one. And again, if you're still struggling after that, recross through a different strut.
Thank you very much.
Thanks a lot. And so then we can move to the next case. This is a case of instant thrombosis in a bifurcation lesion, Valeria Paradise.
So good afternoon, everyone. It's a great pleasure to be here with this outstanding panel, and thank you EBC and Women as One for the kind invitation. So I'm going to discuss with you a case of instant thrombosis in a bifurcation lesion. So I was called at 2 a.m. in the night for a STEMI anterior in a 76-year-old gentleman. He was treated by the ambulance with ticagrelor, aspirin, and heparin. At admission, he was hemodynamically stable. So I started via a radial approach, and you can see here the coronary angiography of the right, mild disease. And then the coronary angiography of the left system showing a subtotal eccentric lesion with a high thrombus burden of the mid-LAD. And you can see from the caudal view, it was involving also the ostium of the diagonal. So what was my strategy to start with? I wired both LAD and the diagonal, and my idea was to proceed with a provisional stenting, but with a mindset of stepwise approach. So let's see what happened to the diagonal and whether we need to stent also the diagonal. But what happened next is that the patient developed ventricular fibrillation. He was resuscitated, promptly resuscitated with electric shock. But what happened during this maneuver is that actually there was a disengagement of the catheter, and I lost the position of the wire in the LAD. And then I tried to re-engage, indeed to rewire the LED, but there was indeed an abrupt vessel closure. And if that was caused by the iatrogenic dissection, so me attempting indeed the rewiring of the LED, and also a component of thrombus dislocation due to the electric shock, I couldn't really say, but I actually insert a wire in the septal as a marker. I achieved the wiring of the diagonal, so I gentle dilate the diagonal with a 2O balloon with the hope actually to get some flow into the LED. And actually that allowed me to a minimal visualization of the LED, but the lesion was really unstable. So that was temporary. Again, no flow in the LED. After several attempts, I wired the LED and the diagonal. And then in the decision-making strategy, we have now a scenario which was slightly different from what we had at the beginning. So we have now a severely diseased diagonal, dissection, plaque shift, a combination of both. The approach was, again, provisional stenting with the mindset of stepwise approach. So I implanted a ultra-thin strat stent, 3024. But I want to focus your attention. So the red marker indicate where I implanted the stent, that there was a mild, so I'm gonna get back. There was a mild myocardial breach just after the takeoff of the diagonal. So my thought was, I'm gonna try to avoid the myocardial breach. And due to the really suboptimal result in the diagonal, I upgrade the technique, so I proceed with the implantation of a stent into the diagonal with a tap technique, 2.5, 28. I completed the procedure with a final kissing balloon and then with a pot, non-compliant 3.5, as recommended. But this is the final flow in the LED, so I achieved the TIMI flow 2 in the LED. And I had a patient, a 76-year-old patient with just one HPR criterion, considering the thrombus load, considering 2 stents, and the TIMI flow 2 in the LED in the context of an acute coronary syndrome. I thought that maybe the help of a GP2B3A inhibitors was not a bad idea. But this is not the end of the case, because after a few hours, I was called back into the hospital for the same patient who developed chest pain and new ST elevation in anterior leads. And you can see here that there was instant thrombosis with a good visualization of the diagonal, but no flow in the LED. So what I did, I again gentle dilate the LED. I perform OCT at this stage, but due to high amount of thrombus, I couldn't get any good quality OCT images. And the angiography was really suggesting distal edge dissection. So underlying mechanisms at this point of the instant thrombosis. Distal edge dissection was something that I left untreated during the first procedure, was something I caused during the dilatation. I cannot rule out that there was also some prothrombotic effect of the myocardial breach. And also I want to discuss with you the use of the very low strat thickness, because if we know on one hand that the very low strat thickness stent really favors the local hemodynamics in terms of low flow of low less areas of recirculation of blood, and also lower oscillatory shear stress. And we know from bench side and from animal study that this is associated with low risk of thrombosis and stent restenosis. But the other side of the medal is, of course, the poor scaffolding. And with this consensus document in mind, you know, that we have to try to avoid the repeat stenting in the context of stent thrombosis, though the angiographic images of a clear distal edge dissection and also the potential mechanisms of the poor scaffolding of a very low strut stent, I decided to implant at this time 18 micron stent, this time 3033. And then I completed the procedure with a final kissing balloon and a pot. I could actually, at this point, it's not running? No. No. I perform OCT.
Can you start manually OCT?
Oh, no. So, okay, on the left, on the right side of the panel, you see that there was a distal edge dissection again, and that was actually limited to the intima. Well, okay, let's just move to the OCT. It was limited to the intima, but extending to almost 2 quadrants and also longer than 5 millimeter. And then moving forward, if you believe me, there was we could see some intrastent plaque protrusion, and then the 2 overlapping stents. The ostium of the diagonal was good open with no overhanging struts in front of the ostium, and the distal edge was good. So good stent apposition and expansion. So what I did, I implanted a short stent at the distal edge, and this was my final result. So my take-home messages or learning points from this case is that underlying mechanisms of stent thrombosis may be multifactorial and sometimes remain unknown. But more important is that a good strategy planning is pivotal, but we have to be prone to modify the technique and the procedure in case of dynamic lesion features. Thank you for the attention.
Thank you very much, Valeria. It's open for questions. Let's.
I wonder, on the last image, we don't see any septal branch or diagonal branch in the stented parts, and so I wonder if you accidentally did not stent the subintimal space after rewiring the LAD, and that might explain the slow flow. I don't know if the imaging showed a re-entry zone or something like that.
Well, with the OCT, I actually demonstrated that I was in the true lumen, so that was not my concern.
Okay. It's just on the last image, there is absolutely no septal branch on a long part on the LAD, but okay, all right.
Neves?
You're talking about strut thickness and stent to
Yeah, it's okay. It's okay.
You're considering that the thin strut, very thin strut, ultra thin strut stent is related to some of the part of the event, but
absolutely
if you calculate the stented area, the stent area versus vessel area, it's all about 16% or 14%. So I really would wonder if that would really have an effect on the amount of protruding material. We haven't seen that on any studies yet.
No, Robert, that's a very good point indeed. I mean, my concern afterwards was maybe the poor scaffolding of the low strut thickness of the stent. On the other hand, I mean, we know that they have some potential, but whether we should use this kind of platform in the context of an acute coronary syndrome, with a high thrombus burden, that it's absolutely on the table for discussion.
No, thank you, Valeria. Very nice case. I was going to ask you if maybe this area that you thought was a myocardial breach could actually be just another stenosis, another plaque, and this could have maybe been the cause of this slow flow because you didn't cover all the lesion, and of course the slow flow was the cause of the thrombosis, and that's why everything solved in the end when you covered that with another stent. I mean, seeing in retrospective, of course, which is always much easier. It's also not the most frequent location of myocardial breach. It's a bit too high. Maybe Javier can comment on that. So maybe it's just this was part of the mechanism
Residual
that there was there plaque. Together with the protrusion that I agree is also incrementing the risk of thrombosis.
I have a general comment
Sure.
imaging.
Yeah.
Because we are asking imaging to clarify some doubts.
Hmm.
And then normally we are recommending when we are in trouble, especially when they are complex cases, to use imaging before to be in trouble. While we are seeing that we are using imaging afterwards. And then if you are asking imaging to clarify, you need to see.
Yeah.
And during the stent thrombosis, you have only two chances. One is I wanted to see immediately now. And so you needed to establish the flow the best that you can and try to see eventually where the thrombus is. In this case, you did OCT before having a really optimal results on the lumen patterns.
Mm-hmm.
The other point is I'm going to treat with the drugs and I'm going to switch the time for seeing 24 or 48 hours afterwards. That was done in the very, very important to try, sorry for the microphone, very, very important to ask to the imaging to clarify the doubts. It's strange now to see the people that are still making speculation, and it means that this imaging were not clarifying the problems. And so it's very, very important. Not always easy when you have a thrombus.
Yes, but it was at 2 in the morning on an acute MRI. Just as a reminder. Yeah. Okay, let's go to the last case. New coronary stenosis after simultaneous kissing stent technique, and it's Sandra Zengebil that will present. Sandra, please.
Thank you very much for the invitation. Okay, so I'm not going to present a complication, an acute complication, but rather a very tardive, long-term complication of the SKS technique. Okay, so we can move to the next to the next one. Thank you. So it's a 52-year-old patient who had a history of ischemic cardiopathy with an SKS technique performed on the LAD and the first diagonal in 2013, and PCI also on the right coronary artery and the circumflex before that, and who presented again with an atypical angina with a positive stress MRI in June 2022 with showing an anterior and lateral hypoperfusion. We can move to the next one. Sorry. Yes, I'm sorry. Okay, so this is the diagnostic coronary angiography. So you can see that there is an intermediate stenosis on the proximal circumflex artery with a significant stenosis on the distal circumflex as well. No restenosis of the stent of the circumflex. And this very calcified and significant lesion of the new carina of the SKS performed on the LAD and the first diagonal, with another lesion on the mid-LAD that is also significant. So just other images to show you a bit more. And so you have this caudal view as well, and the right coronary artery was infiltrated with no significant stenosis, and in particular no restenosis of the stent. So we performed FFR on the LAD, which was positive at 0.68. And we performed the PCI of this LAD lesion. So you can see it better here with the guiding catheter. We used, our strategy was to do an inverted provisional stenting towards the first diagonal. And so we wired the LAD first and then the first diagonal through both stents, so the LAD stent and the first diagonal stent first. And then we tried to wire with a third guide wire the diagonal through the proximal part of the LAD stent, that is to say to cross the last struts of the first diagonal, in order then to crush the proximal part of the LAD of the diagonal stent. But as you can see, we failed to do this with the cyan blue guide wire, so we had to use a microcatheter to do it. Oh, I'll try to show you. Doesn't work. I don't know if it's possible to see the image on the right. No. Well, we managed to do it with the microcatheter, and
you have to click on the image. If you click on the image, theoretically it should work.
Yeah, but it doesn't. Yeah, it doesn't work. So we managed to do it with the microcatheter with a Gladius guide wire, and as you can see it here. And then we tried to deliver a first balloon through the distal struts of the diagonal stent, 2.0 times 15 millimeters balloon, but it was not an easy task. Oh, so the second one never works. It's okay. So we failed to deliver this balloon, and finally we had to use. It doesn't work at all. Is it possible to pass the? Oh, okay. Oh, okay. Okay, so. Is it possible to see the previous one? No? Okay.
But okay, if we cannot see the image, you can comment maybe.
Yes,
no?
yes. So we failed to deliver the first balloon, which was a 2.0, and we had to use a smaller balloon, which was a 1.5. It worked, so we could open the struts, the distal struts of the diagonal stent, and then, we used the 2.0 balloon to open even more the struts. And finally,
technical issue. Let's see if we can go back to the point.
Yes, maybe.
That's normal. Normally, I mean, happen to anybody anywhere.
Yes. So here we were. Okay. So the 2.0 balloon. Okay. And then we had a pretty nice result on the stenosis. So then we took a larger balloon, so Trek 2.5 at first at 15 atmospheres, and then an AccuForce 2.5 at 25 atmospheres to really crush the proximal part of the diagonal of the first diagonal stent, in order to do the inverted provisional stenting from the LAD to the first diagonal. So then we put a Xience stent of 3 millimeters, And we potted it with an AccuForce of 3 × 8 at 15 atmospheres. We had an intermediate good result, so I cannot show you. And then we recrossed, we rewired the LAD through the distal struts as usual. And we exchanged the guide wires. And finally did the final kissing balloon with a very good result. So I'm sorry not to be able to show you. And we took care as well of the mid-LAD stenosis with another stent. This case was about to show how it can be challenging and very time-consuming to deal with an SKS stenosis because it took us 1 hour and 40 minutes to perform it, and a lot of contrast as well, 190 milliliters of contrast, with a high amount of X-rays as well, and various tools, numerous tools that had to be used. So this is not an unusual case. It's not an exceptional case because it's up to 40% restenosis after an SKS technique. So it can be really challenging. So maybe it is interesting to see that SKS technique can be maybe it's possible to choose something else for bifurcation lesions. Thank you very much for your attention.
So first of all, congrats to have keep going. That's what you have to do. Don't worry. I mean, these technical things happen sometimes. My comment is, what about imaging? Because I think that in case of failure of restenosis, as Julia was saying, I mean, it's such an expert of imaging. I think that sometimes you can answer to your question. We know that it was, also related to the procedure technique decided, but what about imaging and maybe also imaging guidance? Maybe you could have spared some contrast, by the way.
Yes, we thought about it, but it was actually very complicated to wire the diagonal at first. So it was...
To get imaging, you needed to cross. That is the point. And I'm not sure that it was so easy to...
No, exactly. We took a long time to cross, and it was the critical...
It's very important to understand that that is another one. Thank you. So it's very important to understand that the level of performance of imaging catheter today is not exactly what they are recommending doing complex bifurcation. They can see in terms of quality, but before seeing, you needed to track down.
Yes.
And you have a calcium, you have a band, you have this type of protrusion of carina. So we needed to have a call for all the manufacturers, and they are starting moving now, to get a better delivery in this catheter.
But there was restenosis in the LAD also. In the LAD you were able to cross, so you could at least start to see what was happening in the restenosis of the LAD. It was underexpanded. What was the issue? So then the second problem was the diagonal.
In my personal practice, I rarely saw cases of SKS restenosis, but what I learned is that the easiest, for me at least, was to go into the main branch, crush whatever is protruding, do pot, and then recross, do kissing, and then continue. So take care mainly of the main vessel. So that was technically easier for me. If there are more questions, Marie-Claude?
No, I was just going to echo what Aleide mentioned. Instant restenosis is one situation where I definitely image because I want to understand what's happening. And more importantly, you want to prevent that patient from coming back again with the same problem. So you want to do a good job. I'm sure you've done a good job first time around, but because the patient has come back the second time around is to is to image and have an understanding of what is happening.
I think it was very, very nice case and illustrates the challenges and very nice way of solving it. Just to highlight that sometimes what I find very useful in this situation is stent enhancement. I mean, sometimes, you know, when you, it's a different type of imaging, but really if you place a stent, a balloon with the two markers in the LAD, then by stent enhancement you may get some clues, you know, and even make sure that you are making progress in the right direction with the wire. So just to share another way of imaging.
I think it's very important to have in mind that this is initially SKS technique. So it means that you have a neo-endothelization between the two stents, all along the two stents. So IVUS will give you the information if you are able to do it, or FDI or CT. But you know what is the problem. The problem is a neo-endothelization in the middle of the vessel. So it's very difficult to treat. And the only way to do it is to do what they have done, so crush the stent, the diagonal stent, in order to be able to restore a new bifurcation with a kind of provisional approach with one stent. And this is exactly what they have done.
Yeah, that's a good point, because when we were looking at the difficulty to enter in the diagonal, I say, no, she's outside proximally. And in fact, no, you agree, she's in the other side of the carina. Yeah. Yeah. Okay.
Yeah. Okay, before
Excellent.
Mary Claude closes, thank you very much. Excellent case. I would like to thank everyone for being here to help us build the session Women as One at EBC. I think it was great initiative by all these people sitting here. I thank all the presenters, all the faculty, and I would like to inform you that all 17 cases that we received were reviewed by 5 independent reviewers and graded, and all the cases according to grades were distributed throughout the EBC program. So you didn't see all. The rest of the cases you can see in other sessions, and I hope that next year we will go even with better organization, and I apologize for all mistakes during the organization. So now I would like to ask Mary Claude to close the session.
No, thank you, but you said everything. It was, yeah, as a Woman as One co-founder, extremely proud of our presenters. What you show was really excellent, wonderful. They are all in the, I would like to promote a little bit the talent directory. Is the good way for women to register and being in podium after, because they will be recognized. And I was extremely happy of this session. Thank you to all, not only presenters but also chairman. The discussion were incredible. So this was a really good session for that. Thanks a lot.